Yeah, but she can always press leave meeting. Host.
होस्ट तो गणेश है.
तो गणेश आहात का तुम्ही?
शिल्पा, अगर हम लोग को शेयर स्क्रीन करना है तो हम लोग को भी होस्ट बनाना पड़ेगा ना, अगर.
हाँ, गणेश को बोलो ना, आपको होस्ट बनाए.
क्या
हेलो
करना है, स्मृति को निकालना है.
हाँ
सर,
सर.
यूट्यूब लिंक एक्टिव हो गई.
ओके. हाँ गणेश, जरा होस्ट बना देंगे हम लोग को, क्योंकि अगर शेयर कर रहा है
यस सर.
स्क्रीन तो.
सर कर सकते हैं आप, फिर भी आपको को होस्ट कर देता हूँ.
और वो स्मृति को एक बार
क्या
स्मृति को
प्रॉब्लम
क्या
आ रहा है
करना
सर?
है.
Priti has joined.
जो है,
इसको निकालूं क्या.
हाँ राव सर, निकालो उसको.
उसका फोन है
याच्यामध्ये
शायद.
येत आहे म्यूट आस्क स्टार्ट व्हिडिओ चॅट.
हाँ स्मृति. हेलो. हाँ. आप लीव नहीं हो रहा है आपके यहाँ से.
मैं रिमूव करता हूँ.
ऑलरेडी. हाँ ओके, मैं बोलता हूँ. हाँ,
उसको रिमूव किया है.
मैं बोलता हूँ. क्या
रिज्वाइन करने को बोलो.
सर
स्मृति
अभी
को.
उनको है ना कैशे क्लियर करके रिजॉइन करने को बोलिए.
उनका ना वो एक्चुअली दूसरे डिवाइस से ज्वाइन कर रहे हैं, तो उनको यहाँ से एक बार आप हटा दो, क्योंकि.
निकाला मैंने निकाल दिया.
हाँ, देन शी ज्वाइन अगेन थ्रू अनदर डिवाइस.
निकाल दिया.
अपने स्पीकर्स का स्क्रीन शेयर चेक करना है क्या सर?
वेलकम डॉक्टर विवेक सर.
Hello.
यस वेलकम.
स्मृति join finally.
Yes, sir. So sorry for the technical problem, sir.
No problem. So we'll start now. It's already 5:32.
Sure, sir.
Okay. We already have about 54 people who have joined. So
Yes,
good
sir.
evening to all of you. On behalf of IIT Guruji, I invite you to our monthly webinar. Since this is a vacation month, we decided to have a webinar instead of the physical CME, which we will plan next month. So in spite of vacation, we already have near about 150 registrations. And thanks to SAMS for providing us this wonderful platform so we can conduct our academic activities regularly. Our president, Dr. Amola madam, is out of India. She would have loved to join, but today she's not there. She said she'll try to join. So now let's start with today's webinar on daycare anesthesia. I invite Dr. Shilpa Tivaskar madam to come and introduce the topics and the MOC for today's webinar.
Thank you, Dr. Rao sir. Yeah, welcome everybody. As we know, daycare surgery is never daycare for the anesthesiologist. It is always a daycare concept for the patients and the hospital. For us, it may be ERAS, but we have to follow all the preoperative investigations and all the PAC protocols. Also, for us, the most important period of daycare surgeries, the most risky period is the post-operative period. So today, all our great speakers, first of all, I thank my scientific team to select this topic, which is very pertinent to today's era, because we have ERAs there, we have surgeons who are requesting early discharge, and hence we all should be aware that what precautions we should take during this daycare procedures. So without wasting time, I hand over to Dr. Smriti and Dr. Tejveer Singh, sir, for the proceedings.
Thank you
Let
so
me-
much, ma'am.
Yeah. Let me introduce Dr. Smriti. She is a dynamic anesthesiologist. Dr. Tejveer, sir, can I have the CV of Dr. Smriti?
Yes.
Yeah. So Dr. Smriti is is an anesthesiologist, fellow pediatric anesthesia under MUHS from Surya Hospital, fellow pediatric regional anesthesiologist from under AORA with CAS, and freelance consultant anesthesiologist Mumbai, and to attach to almost all the major hospitals, Criticare Hospital, Siddhachal Hospitals, Shushrusha Hospital, Ramakrishna Mission Hospital. Thank you, Dr. Smriti, for being taken the part of MOC along with Dr. Tej, sir. It's really nice to have you.
Thank you so much, ma'am.
Over to-
Thank you so much, ma'am. Thank you so much, ma'am, for this introduction. Good evening to everyone. I would like to send a very warm welcome to everyone who have graciously decided to spend their Friday evening with us today. Today's topic is a very practical one, a case of which I'm sure everyone must have encountered at some point in time or the other in their day-to-day practice. We will be discussing about 4 topics today, and you can expect that each speaker will have the floor for about 20 minutes. After the completion of all 4 topics, we would be having a panel discussion for about an hour, during which we will be joined by experts in these fields. This will be an opportunity for us to learn from each other and grow together. All questions will be entertained during the panel discussion, and chat box questions are also welcome. Hopefully, by the end of our time today here, we will feel more comfortable and confident regarding daycare surgery. And now, without further ado, I would like to introduce our first speaker for today. Today is Gauri ma'am, a part of our webinar already.
Yeah. Oh, sorry. Yeah.
Hello, am I audible, Smriti? Yes, ma'am. So for the first topic we have, which is the dental rehabilitation, we have Dr. Gauri Pawar with us today. I would like to introduce her as she's done her fellowship in pediatric anesthesia from Vijayawada Hospital for Children. At present, she is a freelance consultant pediatric anesthesiologist, along with being a consultant at Vijayawada itself. Over to Dr. Gauri. Gauri ma'am, you have the floor for about.
Yeah.
Let me stop my.
Smriti, I'll start my screen sharing. Hello.
Hanji ma'am,
Just a
please.
second, ma'am.
Yes, ma'am, please.
Uh, is my screen visible? Smriti?
Yes,
Yes,
madam.
ma'am.
Yes.
Yes,
Yes,
ma'am.
ma'am, it is visible.
Okay, fine. Good evening, everyone. First of all, I would like to thank Forensic Society of Anesthesia and Dr. Rajesh Rao, sir, for giving me this opportunity. My topic is anesthesia for daycare dental rehab procedures. First of all, what is daycare anesthesia? It is also called as ambulatory anesthesia when the patient is admitted on the same day of surgery. The surgeries are generally planned, elective, non-emergency procedures with no possible predicted risk of major post-operative complications. And the patient is discharged on the very same day in the first 24 hours of surgery. Now, there are many advantages of daycare surgeries and anesthesias, like reduced chances of nosocomial infections, then cost effectiveness, then hospital bed availability. But I think the most important for us as well as to the patient is that the patient can go home and recover in the friendly, comfortable environment. Now, there are many dental procedures which are done on daycare basis, and they're like dental treatments like dental extractions, canals, pulpectomies, spacer replacement, fillings, fluoride therapies. And all these procedures are done, most of the times are managed on dental chair with local anesthesia, with or without behavioral therapy. But there are certain class of patients who will need anesthesia in some form for the same procedures. And generally, they are all the pediatric patients, generally less than around 10 to 12 years of age group, who are extremely anxious, apprehensive, not cooperating, needle phobic, stranger phobic. Then the ASA2 pediatric patients, like the syndromic ones, autistic, with developmental delay, cerebral palsy, attention deficit disorders, hearing, vision, and speech disorders. And some adults and adolescents who have got physical, cognitive, emotional, or severe intellectual disability. Or some are just extremely phobic about the treatment and won't let you touch. So they are the class of patient who will need anesthesia in some form for dental. Important part of the dental daycare rehab procedure is the pre-operative assessment, and which includes the thorough history and examination. Now, as a general practitioner, we all know that we get to see our patients most of the times on the day of the procedures. And for daycare procedures, sometimes it can lead to unwanted cancellation of the surgeries or a prolonged stay or some complications which can lead to readmission. So thorough history is very important, either on the day of surgery or sometimes and pre-op visits a few days prior if the patient is syndromic or with some systemic disorders, so that we can always examine the patient, screen the patient to see if the patient is really fit for the daycare procedure or not, and optimize if necessary. So, apart from the routine general history of general medical history, surgical history, drug history, history of chronic and recent illnesses, the most important history pertaining to the dental procedure is the history of bleeding disorders, history of snoring, mouth breathing, or adenotonsis, which might change a plan of anesthesia, history of known allergies to the local anesthetics, and in pediatric patients, the history of anesthesia-related complications in the family, especially to rule out the malignant liver. After the thorough history, the most important is the systemic and the airway examination. Now, most of the times, the dental patients being uncooperative, associated intellectual disabilities, we might not get a proper opportunity to examine them properly. Even sometimes the dental surgeons, they don't get to see or examine the oral cavity properly before the procedure. So sometimes we have to, induce them, sedate them, and then only the surgeon can examine the oral cavity and decide what procedure to be performed. And accordingly, a plan of anesthesia can also change. This is the best time to locate the IV site for the patient, check the level of cooperation and understanding to plan the mode of anesthesia. Now, fitness is generally, as we all know, for anesthesia is given by us. But sometimes for dental procedures, for daycare procedures, we can take fitness help from other specialities like pediatricians, neurophysicians, cardiologists. Depending upon the extensiveness of the procedure and underlying patient conditions. And also the medication instructions are given in the same settings, like which, depending upon the physician's instruction, which medications to be given in the morning on the day of surgery, which to avoid. The proper written, informed, valid consent is taken either from the patient or from the guardians or the caretakers after explaining the anesthesia techniques, the analgesia modalities to be used, and the associated complications. If you are visiting, if you are giving a visit few days prior, always mention properly the time of admission in the hospital. And if the fitness has been given prior, always review the patient on the day of surgery. Now, whatever is the procedure, how small it is, the mode of anesthesia, the age of the patient, for daycare dental procedures also will stick to the ASA routine fasting guidelines, which is 2 hours for the clear liquids, 6 hours for the light meal, non-human milk, formula fed, and 8 hours for the heavy fatty. Generally, for the dental daycare procedure.
Uh, Sorry, ma'am, apologies for the interruption. Your mic does not seem to be stable. Is there a possibility that you can stabilize your mic a bit and continue the lecture?
I am audible, right? Or my voice is breaking in between?
Your voice is waxing and waning. आ जा रही है आपकी आवाज.
Now,
This is
अभी
full.
ठीक है?
Now it's absolutely clear now. Yeah.
अभी ठीक है?
Better,
Yeah.
better. Thank you so much,
Okay.
ma'am.
Okay, fine. So the
Sorry.
investigation, no, that's okay. So investigation for the dental daycare procedure threshold, the screening threshold is always low. We will avoid over investigating for the procedures. So we'll always stick to the routine basic CBC and coagulation profile, which are must for the dental procedures. And always depending upon the patient, the procedure, and the systemic conditions, syndromes, we can always add the further investigations like chest X-ray, ECG, 2D echo, thyroid, LFTs, RFTs. But the routine basic investigation is CBC and coag profile, and rule is to avoid over investigating the patient. So our inclusion criteria for the daycare dental procedures will be all our ASA1 patients who are anxious, phobic, uncooperative, ASA2 patients who are syndromic but not having any major systemic involvement, and patients with systemic disorders which are always controlled and optimized. We can always take our autistic, ADHD, CP patients who have got active lifestyle but not those who are not very crippled, severely crippled or bedridden. Controlled epilepsy. We can include for daycare procedures those who are on regular medications, on regular follow-up with the neurophysicians, and when there's no recent history of epileptic attack. Will generally exclude patients who are morbidly obese with severe OSA who might be needing BiPAP or CPAP for the same. Patients with risk of aspirations, patients with risk of difficult airway, will exclude them from the daycare dental procedures. Now, like a patient selection, the operating setup selection is equally important to have a hassle-free procedures. The first and the most important is the gas supply, which is oxygen, of course, and the nitrous oxide. It should be reliable and unending. It can be either a central supply, or if it is in the cylinders, then always check for the availability of the backup cylinders. Always check if they are full or empty, the pressure gauge working or not, and the tubings. The basic monitoring equipment should be available like heart rate, ECG, NIBP, pulse ox, and etc. All anesthesia medications should be easily available with the checked expiry dates. Same is with the crash carts, the emergency medications with the check expiry dates, age appropriate airway instruments, defibrillator, a functioning suction, and trained staff, which is really difficult to get anesthesia trained staff for the procedures. Now, before we go to the various modes of anesthesia for the dental daycare procedures, we have to keep in mind to choose our drugs wisely. So that there's, the aim is to use the drug medications which have got rapid onset, rapid and clear recovery, pleasant recovery, and with a minimum post-operative complications, and so that the patient can resume the pre-operative functional status rapidly. Now, the most common type of anesthesia used for the daycare dental procedure is the conscious sedation. Now, what is conscious sedation? It is a drug-induced depression of the central nervous system where the patient is maintaining the cardiorespiratory system and responding to the verbal stimuli alone or with the tactile stimulation. The patient selection for the conscious sedation is very important. Now, generally, patients who are very apprehensive but can be counseled, they are little older children, adults or adolescents, and even the procedure, the short procedures which are not very extensive, not very painful, we can include those patients for the conscious sedations. The challenges in the conscious sedation is that we are sharing unprotected airway with the dental surgeon. So there are high chances of we losing the airway, high chances of patient getting aspirations, laryngospasms, bronchospasms, and we might need assistance for the respiration, breathing. Now, there are four levels of sedations for four levels of conscious sedation. The first one is just the mild sedation, where just the cognitive and coordination is impaired. Moderate level 1, where the patient responds to verbal commands. Moderate level 2, this patient needs tactile stimulation for the communication. And the fourth one is the deep painful stimulation. We don't want to go to that level. Before we go to the pharmacology of the daycare dental procedures, we have to keep in mind that no single drug will give you the adequate anesthesia, analgesia, and operative condition. Most of the times, we have to use the drugs in combination in titrated dosages, either inhalational alone or TIVA or inhalational with IV agents to get the optimum operative conditions. The most commonly used agent is the nitrous oxide in the daycare procedures because we all know that it can be easily titrated with oxygen starting from concentration of 30%, maximum we can go up to 60% to achieve adequate analgesia, anxiolysis, and amnesia. It has got rapid onset, rapid and complete recovery, and at the same time, it gives us the patient who's perfect for the dental procedure. Relaxed, comfortable, cooperative, and communicable. It also gives varying degrees of muscle relaxation so that there's reduced gagging and abnormal movement when the surgeon is operating and no respiratory depression. The disadvantages is that nausea, vomiting, and we have to explain the patient that uh, not to involve in the skillful motor activity at least for half an hour to 1 hour after the sedation because it is impaired at least for 20 minutes following sedation. Sevoflurane, we all know it is the most commonly used inhalational anesthetic agent, which has got gas solubility, non-pungent, rapid onset, rapid recovery, and easy titration with minimum cardiorespiratory effects. Now, we can always add sevoflurane in our inhalational agents like oxygen and nitrous oxide to deepen the levels of anesthesia. When we want a moderate level 1 or level 2 anesthesia to make patients little more sedated and more cooperative. We can always start with a MAC of around 1.5 of sevoflurane. And when the local anesthesia has been administered and patient is comfortable with other agents and local anesthetic, we can always reduce the MAC level to around 0.5, 0.75 to get a more comfortable patient and ease of operability. The next is the benzodiazepines groups. The most commonly we are using is the midazolam. Good anxiolysis, amnesia, and anticonvulsant effect. We can administer it most commonly for dental procedure, transmucosal administration, that is oral and nasal. This is commonly used in the pediatric patients or adolescents or adults who are difficult to get into the operation theater, are anxious about the parental separation. So most commonly, transmucosal route is used in pediatric patients. It can also be used as intravenous agent in conscious sedation with either other inhalational agents or IV agents. Always, it has to be administered in the sub-anesthetic dosages, like starting with 0.03 to 0.05 mg per kg, rather than using a full anesthesia drug dose of about 0.1 mg per kg, which can give respiratory depression, restlessness. The most common side effect is the disorientation and disinhibition, which is not desirable in dental setups. So always start with a smaller dosages, give in incremental titrated dosages are given to avoid undue side effects. Next IV drug which is commonly used in dental setups is ketamine. It gives a trance-like state. As we all know, it is a dissociative anesthetic and profound analgesic. So it provides good analgesia, amnesia, as well as anesthesia. It can also be given orally. It can be given easily, and at the same time, we can give IM if the patient is not tolerating oral administration. Same for the pediatric patients or adolescents who are very difficult to get up to the OT table, and can also be used as agent for TIVA or along with other anesthetic or other inhalational agents. We are using this in the sub-anesthetic dosages around 0.5 to 1 mg per kg to avoid side effects like increased salivation, nausea, vomiting, hallucination. We can always use ketamine in combination with midazolam, ketamine with propofol, ketamine with dexmedetomidine to achieve the desired effects. We have to always choose the agents which can help the patient to become more cooperative, pain-free, as well as sedated.
5 minutes more.
Yeah. The next one is the propofol, the most commonly used agent in the sub-anesthetic dosages, which will also has a advantages of no PONV, clear recovery. Dexmedetomidine, as we all know, it is a good, the most promising agent in the daycare surgery nowadays. When used in sub-anesthetic dosages, it has lesser side effects like bradycardia and hypotension. Last adjunct is the general anesthesia reserved for pediatric patients, preschoolers, procedures of more than 1 hour, procedures which are painful, and when LA is contraindicated. We have to always pre-medicate them, induce with sevoflurane, take IV cannula, and the airway secured with endotracheal tube, either nasal or oral and throat pack. Advantages is that no risk of aspiration, airway is protected. We can titrate our dosages properly to get a good depth of anesthesia. Important part is that we can always go opioid free when we have other drugs available like dexmedetomidine, NSAIDs, paracetamol, and always take advantages of local infiltration. Dual therapy, dexamethasone and ondansetron to prevent nausea, vomiting. Recovery scores we are using for ward readiness is ALDRIT and for home readiness is PADS. We all know the ALDRIT score and the PADS score. The discharge criteria is always review the patient by dentist or anesthetist either physically or on telephonically. Other criteria is that IV cannula removed or take resumed. Patient has no bleeding, nausea, vomiting, minimum pain. Patient should be conscious oriented. Always ensure responsible adult escort as well as for the escort as well as for the home care. Written and verbal instructions are given for the post-operative care, medications and diet. And always inform about the possible complications and when to contact hospital. And the last thing is that the complications which can delay our discharge and which can give rise to readmissions is the dental pain, oral swelling, tongue swelling, lip swelling, difficulty eating, swallowing, nasal, oral bleeding, throat discomfort, nose discomfort, weakness, sleep alteration, drowsiness, nausea, vomiting, hoarseness. So these all complications can delay the discharge and can give rise to readmissions, unnecessary readmissions. So to summarize is that for the dental daycare procedure to be a successful daycare dental procedures, we always have to choose the patient wisely, choose the setup wisely, choose our medications wisely, and always expertise in dental surgery as well as the anesthesia field. Thank you so much.
Thank you so much, ma'am, for this amazing lecture. We will take the question and answers during the panel discussion. Should we proceed with the next lecture? Is Dr. Ankit Desai with us today?
Yes, Nityan.
Thank you, sir, for joining us. Dr. Ankit Desai will be taking a lecture on pediatric ophthalmic procedures. Dr. Ankit is the founder director for Children's Anesthesia Services and is affiliated with various hospitals such as Nanavati, Surya, Breach Candy, and Wockhardt. He also has multiple publications, lectures, book chapters with regards to pediatric anesthesia in his name. His special interests are pediatric regional anesthesia and pediatric airway. Over to Ankit, sir.
Is my screen visible, Smriti?
Yes, sir.
Yeah, am I audible?
Yes, sir.
Clear.
Okay. So my topic for today is pediatric ophthalmic procedures. At the outset, I would like to thank the organizers for calling me here. And one observation that I made today is I am probably, for the first time in my life, I am probably the eldest of all the speakers. So I think I would like to compliment the BSA office bearers for giving the younger dynamic speakers an opportunity to speak at these platforms. This has happened to me for the first time. Probably I am also getting old now. So this is my disclaimer. I have no conflict of interest. So in today's topic, I'll be covering all the procedures, ophthalmic procedures in the pediatric age group. We'll be discussing the challenges that are there in our kinds of setups during these procedures. We'll discuss about the blocks in ophthalmic anesthesia. We'll discuss about the drugs and drug related complications, and we'll also discuss some of the complications which are specific to the ophthalmic procedures. So the commonest procedure that we do in our kinds of setup is the squint surgery. Squint has an incidence of around 3 to 5% in the population, and it's one of the most common procedures that we do. Second most common is cataract, EUA, ptosis surgery is also is a common. Then we have blocked nasolacrimal ducts, for which we have various options like syringing probing, or you may have a DCR, or now many of the surgeons are doing an endoscopic DCR. So our anesthesia concerns are different for these kinds of procedures. Also, we have a lot of specialized procedures like ROP. For most common thing that we do is a laser procedure. Sometimes you have some injections, anti-VEGF factors, etc. in these kinds of patients. Then you have traumatic eye injuries, then corneal grafts, vitreoretinal surgeries, and very rare ones are the retinoblastoma, coloboma, etc., which we do sometimes. Uh, Very rarely we do them. So the challenges that we have in our kinds of setup, the most common challenge is the setup. Setups that we have in our kinds of especially in our areas, most of the ophthalmic setups anesthesia wise are a challenge for us. They are a challenge in terms of the help that we get, the workstations that we have, right from getting drugs, etc. I think everyone can relate to what I am trying to say over here. Then another challenge is the age group. So on one side, you have a small neonate for cataract surgery who would be just like 15 days to 1 month old. We have adolescents. Adolescents nowadays can be very obese and can reach up to 100 kgs. So that is a challenge for us. Then we have complex procedures at an earlier age group. So with all the branches now, surgeons want to do the procedures at an earlier age. So it's something like a cataract, they want to do as early as possible. So that offers a challenge for us. Then you have a lot of syndromes associated with cataract, with ophthalmic procedures. So we have to be aware about the syndromic associations. So as I said, with the setup, we have a challenge. So we may have a setup which may have a simple workstation. Sometimes even you have a wall-mounted workstation. Sometimes we have a proper workstation also available. So every place is different in terms of the things that are available over there. Help is a major issue in these kinds of setups. So even something like shifting patients, inducing a patient, getting the patient inside, especially if the patient is uncooperative, becomes a big challenge for us. Mindset is one of the bigger issues, especially with the senior ophthalmologists. I don't want to say this, but generally ophthalmologists, they are more used to local anesthesia, and they feel that general anesthesia is just sedation, or just thoda sa sedation, they know something of that kind of an attitude, which is not there luckily in the pediatric ophthalmologists that we have nowadays. So mindset is a major challenge for us. Daycare setups, most of the setups are daycare setups, and in case you need an admission, then that becomes an issue for us. Getting a backup also is a big issue for us, and most of the ophthalmologists, if you ask them, they want to do in their setups. So sometimes if we have a neonate or something, if we request them to do in a setup where you have a, say, a neonatal backup available, they will not want to do over there because they don't have their microscopes, other instruments, etc. over there. So that is an issue for us. Now, these are some of the common syndromes that are associated with ophthalmic procedures. Craniocytosis is a very common syndrome. Craniofacial anomaly, Stretcher Collins, Bolton-R syndrome, we will not do in daycare setups. We will simply avoid them, and this should be done in hospital kinds of setups. Mucopolysaccharidosis, I will never touch a mucopolysaccharidosis patient in a nursing home setup, be it ophthalmic procedure or an orthopedic procedure. These has to be done in a proper setup with a proper PICU backup available. chromosomal anomalies are something that are like associated with ophthalmic procedure. Marfans, they are, if they don't have an aortic root dilatation or too much of an AR, they can be done in our kinds of setups. Other syndromes are also very commonly associated, but the challenge that we have nowadays is an earlier age group at which the patients need to be operated. So neonates, they will require a neonatal backup, especially when you are doing surgeries like ROP, where the surgeon needs absolute immobility, then we may have to give general anesthesia, or even congenital cataracts, we need general anesthesia. So all the challenges that we have with neonates, right from maintaining temperatures to NICU backups or ventilatory support, etc., becomes a challenge in our kinds of setups. So we start with the pre-medication. All patients generally they are anxious during the procedure. Not only the patient, even the parents are anxious. So the most common pre-medication that we use is midazolam. Midazolam can be given orally or nasally in the doses mentioned. Dexmedetomidine is something that we have been using very regularly nowadays in a dose of around 1 to 2 microgram per kg, and it works as good as midazolam. There are some new agents nowadays available like melatonin, etc. According to me, they don't work. These two are the only two agents which actually work. Then another complication which is most specific to ophthalmic procedure is an OCR or oculocardiac reflex. It is most commonly seen with your strabismus or your squint surgeries, can occur with globe surgeries or vitreoretinal surgeries. So generally, when they touch specific muscle groups or they pull or touch, even touching sometimes can lead to profound bradycardia and a sinus arrest. So the only thing most of the times needed is just tell the surgeon to just leave the muscle. Most of the time that will suffice. Sometimes you may have to use atropine or glycopyrrolate to treat this oculocardiac reflex. And in squint surgeries, like medial rectus and the inferior rectus are the two muscles where oculocardiac reflex is most common. That is what we have observed. So when you are doing, when the surgeon is on the working on the medial rectus, be aware that, or be conscious of the fact that you may get an oculocardiac reflex. Then PONV is very common in most ophthalmic procedures after squint surgeries, especially. PONV is like one of the major complications. So most of the times we use a two drug regimen over here. Dexamethasone in a dose of 0.1 to 0.2 milligram per kg at induction, and ondansetron towards the end of the procedure is what we use. And droperidol is used as a rescue for PONV. So suppose if the patient gets vomiting, then droperidol should be used for PONV. So most ophthalmic procedures will receive a two drug regimen for your PONV. Word about the ophthalmic blocks. Ophthalmic blocks are very less frequently used in pediatrics. They are not as common as they are used in adults. The reasons for them for this is the globe volume in pediatrics is greater than 50%. So the eyeball occupies around more than 50% of the globe, whereas it is just 22%. So chances of globe perforation, retrobulbar hemorrhage, etc., is very high in ophthalmic blocks, and most of the pediatric ophthalmologists, they are not very keen on giving blocks. Secondly, if they have given a block, they need dressing for a longer period, which they want to avoid. Like post-operatively, they want to remove the dressings as fast as possible. That is the reason ophthalmic blocks are not very common. But there are advantages related to blocks. So sometimes we do insist on giving blocks. So the advantages are there is absolute akinesia. So there is no movement of the eyeball if a block is given. There is good analgesia. You don't have to use opioids, NSAIDs, etc. You have to use lesser doses. Then it gives a very still field. And if blocks are given, then the chances of oculocardiac reflex is much lesser. So as far whenever possible, you give blocks. So there are three kinds of blocks that are available. First is the intraconal, which is a retrobulbar block, which is behind the eyeball. Then you have a peribulbar block, which is around the eyeball. So retrobulbar will have the maximum complications. Some surgeons, they like to, most of the surgeons, they will give a peribulbar block. But the safest that is there in pediatrics is your subtenons block. So if at all we give a subtenons block, and most of them, most of the cases will be done under topical anesthesia. So topical anesthesia is the most common, with paracaine is the most common anesthesia that we use. So this is a video of the subtenons block. The surgeon will take a small incision over the conjunctiva, and usually it is given in the inferonasal or the inferotemporal region, and just around 2 to 3 ml of local anesthetic, either lignocaine or bupivacaine or combined, can be used for these kinds of blocks. So you take an incision and you inject inside the eyeball. So subtenon's block is what is most commonly used. And as I said, the advantages are many with the blocks. Most important advantages are kinesia. So many times, if the eyeball is moving, then you have to give muscle relaxants also. The movement of the eyeball becomes a major issue during these procedures. If a block is given, then movements are not there. So kinesia is the most important advantage with these blocks. There are certain cases where you have to avoid blocks. So retinoblastoma, you avoid a block. Open globe injuries, no surgeon will allow you to give a block. So open globe injuries, they don't use a block. And glaucoma with raised IOP is where blocks are to be avoided. So if blocks are not used, then the analgesia that we use is topical anesthesia with Paracane, as we already discussed. NSAIDs and PCM we give to all patients. Opioids only if needed, especially in our kinds of setups and with daycare procedures, etc. I tend to avoid opioids. Only when needed, we use opioids, and most common opioid that we use is fentanyl. So there are now the ophthalmic drops. We have to be aware of the side effects and the complications related to ophthalmic blocks. So in glaucoma surgery, you have beta blockers and prostaglandin analogs. Beta blockers can cause severe bradycardia, arrhythmias, bronchospasm also is possible. Even prostaglandin analogs can cause bronchospasm. Carbonic anhydrase inhibitors like acetazolamide, they are mainly used in oral preparations. Many times I get requests for giving oral acetazolamide, etc., to reduce IOP in cataract surgeries. Generally, it is not needed, as I think Siddharth will tell us more about that. Generally, it is not needed because IOP can be easily controlled by them. So acetazolamide most of the times is not needed. Topical NSAIDs can cause bronchospasm and gastrointestinal upset. Phenylephrine is one drug we have to be very, very careful of. It can cause very severe tachycardia and hypertension. I have seen one patient going into VTAC with phenylephrine. Phenylephrine, adrenaline can be used, like when they use for pupillary dilatation, they can cause very severe tachycardia and hypertension. Other drugs like local anesthetic also, they can cause local anesthetic toxicity, especially when you use in neonates. So the dose has, you have to be very careful with smaller babies. You have to be like, you have to calculate the dose and give. Regarding induction agents, ketamine is the drug which causes a lot of raise in IOP. My personal experience is that ketamine in less doses, like 1 to 2 milligram per kg, doesn't cause that much raise in IOP. It causes a very severe raise in IOP only when it is used in very high doses, like 5 milligram per kg, etc. So ketamine may or may not be used. Generally, I tend to avoid ketamine for these kinds of cases. Scoline is another drug which can cause raised IOP, and we generally avoid scoline in these like patients, and especially in some squint surgeries may be associated with muscular dystrophies, etc. And in them, scoline should be avoided. Volatile anesthetics, nitrous oxide, everything is safe. Nitrous oxide, a word of caution is when they are using intraocular gas for retinal detachments, etc. It should be avoided for at least 12 weeks after the gas has been inserted, because it can cause very like it can cause a raise in the IOP, and even globe perforations are reported with nitrous oxide use in these kinds of patients. So now coming to procedures, the most common, one of the commonest procedures is EUA. So EUA is examination under anesthesia. The surgeons will say that I just have to measure some IOP, or I have to do some lens calculations before the cataract surgery, the size calculation, etc. And you just give him some sedation. So most of the times we try with midazolam 0.5 to 1 milligram per kg orally. Sometimes it works, sometimes it doesn't work. Dexmedetomidine, in our experience, it doesn't work for these kinds of procedures. So sometimes you may have to take IV and you have to give ketamine, or you can give oral ketamine. But the most common thing that we use is CO with a face mask. So what we do is we just start oxygen nitrous sevoflurane. We just hold the mask. The surgeon will quickly finish off his procedure, and we can shut off, and you have an awake patient very quickly. So CO with face mask is what we commonly use for these kinds of procedures. Important thing is here is when they come for multiple EUAs, you have to be consistent with what you are using with EUA. So if you use midazolam the first time, then you have to use midazolam only again. You have used sevoflurane, then next time also use sevoflurane only. Then coming to cataract, as we discussed, trend is to do as early as possible. With smaller babies, NICU backup is generally needed. With bigger babies, it is not an issue. Syndromic children is very common. My personal experience is cataract causes because syndromic association is more common with cataract rather than squint surgeries. Cataracts tend to give more trouble than squint surgeries. So cataract you have to be very careful, especially with syndromic children. Surgeons would generally need a motionless eye. Sometimes the most common technique that we use is oxygen nitrous CO induction. We take an IV line with that under inhalational anesthesia. We give some propofol, put in LMA. LMA spontaneous is what we use because that way we have an absolute control over the airway in case the surgeon needs a motionless field. Then we can give relaxant also with an LMA. So LMA spontaneous respiration is with sevoflurane is what we use most commonly. And smooth emergence without bucking, etc., is very important for these kinds of surgeries. You don't need a raise in IOP during extubation, etc. Coming to squint, squint is the most common surgery. CO with spontaneous breathing on LMA is what we most commonly use. Sometimes we give a subtenon's block. As we already said, PONVA and oculocardiac reflex is very common with these surgeries. So you have to be mindful of these complications. NSAIDs and PCM are the most commonly used analgesia that we use. Sometimes we use opioids if these are inadequate. And beware of scoline with patients with myopathy. So sometimes it has an association with myopathy, then scoline has to be avoided in these patients. Coming to blocked nasolacrimal duct, the most common procedure, especially in the younger age group, is sac syringing and probing. And most of the times what happens is surgeon will do a sac syringing and probing. He'll insert some saline inside the nasal cavity. So that can cause aspiration. So I don't like to keep the airway open. I will put at least an LMA with a sevoflurane, like with spontaneous respiration for these kinds of procedures. And generally, I have one sort of suction catheter inside the nostril, which is to be inserted so that you can easily suck out whatever is getting injected. So that is the way I prefer to do sac syringing and probing. DCR, most of the times you will have to intubate with throat pack because sometimes it can cause very severe bleeding. You may have to use some the Otrivin nasal drops, etc., to control the bleeding inside the nose, etc. Endoscopic DCR, many surgeons are doing very frequently. In these kinds of cases, I generally intubate and we do a throat pack, etc. Traumatic eye injuries, open or closed, it can be an open or closed globe injuries. It is an emergency. Sometimes you cannot wait for the fasting of the patient. You may have to do a rapid sequence induction. Scoline is to be avoided in these kinds of cases. So rocuronium is a very good option as against scoline, which may, like scoline may cause an increase in the intraocular pressure. So rocuronium you may have to use. Retinopathy of prematurity, you have multiple treatment options available. Generally, they are small, very premature babies, low birth weight, etc., who have received oxygen in the NICU. Some of the surgeons, they will do a laser procedure in the NICU itself, on the bed itself. They request the pediatrician to give some sedation, and they will do in the NICU itself. Sometimes they come to our ophthalmic setups, and at most of the times, what we do is under MAC, we don't give anything, and generally under topical, like it is adequate. But sometimes the surgeon may need a motionless eye. In that case, we may need an intubation with an NICU backup. So in these kinds of cases, NICU backup is very, very important. Sometimes in these kinds of cases, you have an intra vitreal injection of all those anti-VEGF factors, etc. Those can be done even on a face mask with sevoflurane or something of that sort. Like even if you have halothane, it generally suffices. Coming to retinal surgeries, there are multiple options or multiple surgeries in retina. It can be something like a retinoblastoma, coloboma, detachments, etc. They need specialized management. And as we said, you have to avoid nitrous oxide in whenever the surgeon is using intraocular gas. And after insertion of intraocular gas, nitrous oxide is to be avoided for at least 12 weeks after the procedure. Sometimes you may have to intubate, or even LMA spontaneous suffices for most of the cases. So most important for daycare procedures is avoiding syndromic and smaller age group children in our kinds of setups. So patient selection is very, very important. All investigations should be normal, especially when you are doing in our kinds of setups. And usually we discharge them after they tolerate feed. So generally it's around 3 to 4 hours after the procedure. We generally discharge them at those kind of in that kind of interval. This was a case, in very interesting case, orbital rhabdomyosarcoma that we did, like our team did a couple of days back. This was a 3-year-old child with an orbital rhabdomyosarcoma in which the surgeon had done an enucleation. So this has to be done in a proper setup, in a proper hospital setup with all kinds of backups available. The surgeon took around 6 to 7 hours for the surgery. So you have to be mindful of what cases you can do and what cases you have to avoid in our kinds of setups. Now, coming to some recent developments. So not only are we have to give anesthesia, but nowadays what is coming up is ophthalmic focus. Focus is point of care ultrasound. So we stick to our principles of point of care ultrasound. That is the IAM framework. Focus works with the IAM framework. So we just need an answer of yes, no to our questions, whatever questions that we have. So this is a focus that we have started doing for certain cases. So important thing over here is you have to use an ocular mode because the resolution that has to be used is the minimal possible. That is called as Alara principle, and the eye has to be taped with a tegaderm. So the structures that you see over here, this is the anterior chamber, this is the lens, and this is the retina, and this is the optic now that is visible. So especially in trauma setups, etc., where the sonologist or someone will take time or ophthalmologist is not available immediately and you need a diagnosis. So this is very useful in those kinds of setups. Now, this is a picture showing a lens dislocation, which can be seen on our ultrasound examination. This is a retinal detachment that is very clearly seen over here. Now, one thing that I do very commonly is optic nerve sheet diameter. This is called as ONST measurement. So it is done around 3 millimeters behind the optic disc. So this is the optic disc. We do it at around 3 millimeters behind, and greater than 4.5 millimeters is indicative of a raised intraocular, a raised ICT. So even before doing any lumbar puncture, etc., if ophthalmologist has not done a fundoscopy examination, I always do an ONSD measurement, and if it is less than 4.5 millimeters, only then I go ahead with the lumbar puncture. So that is something that is coming up in the ophthalmology related. So I thought I'll cover with this lecture. Thank you. That's it for me.
Thank you so much, sir. Your lecture has been very informative and extraordinary. I would like to call upon Dr. Jaisal Saldana now for the next lecture on cosmetic surgery.
Hi,
Do
am
we
I
have?
audible?
Yeah, hi. So Dr. Jaisal has done an MUHS course in regional anesthesia. Can we have her? Thank you.
Yeah, hi. Okay.
Yeah, hi. So Dr. Jaisal has done an MUHS course in regional anesthesia and acute pain management from Sancheti Hospital in Pune. She also holds a European diploma in regional anesthesia, EDRA. Currently a practicing freelance consultant anesthesiologist in Mumbai. Welcome, ma'am. Over to you.
Thank you. I'm unable to share my screen. Okay. Okay. Is it visible? Is the screen visible?
Yes, sir.
Yes, ma'am.
Okay. Hi, good evening, everyone. I'm Dr. Jaisal Saldana. I'm going to be talking about anesthesia for daycare cosmetic surgeries. Now, over the years, there's an ever-increasing trend in the cosmetic procedures in India. That's mainly because of increasing awareness, accessibility, and mostly because of increasing social media awareness among the people. As per the International Society of Aesthetic Plastic Surgery, India is almost the fourth most popular hotspot destination for plastic surgeries, amounting to almost 3.5 to 4.5% of the global cosmetic procedures conducted. So when we talk about cosmetic surgeries, it is a word that is synonymously used with plastic surgery. So to understand the fine line of difference between that is that plastic surgery encompasses two forms of surgeries, that is reconstructive and cosmetic. Reconstructive surgeries are medically essential surgeries, which are done to restore the normal appearance and function and correct deformities which may be due to trauma, congenital defects, or some medical condition like cancer. Whereas cosmetic surgeries are mainly aesthetic surgeries. These are surgical and non-surgical procedures that are used to enhance and reshape the structures of the body to improve the appearance and imbibe confidence. So there is a list of cosmetic surgeries. It's an unending list, but just for the sake of ease and understanding right now, we've divided them into surgeries body-wise, that is their face, breast, body, and male-specific surgeries. Face surgeries, brow lift, neck lift, blepharo and rhinoplasties being the most common. Breast surgeries, implants, and liposuction in body surgery is very common. Along with that, there are minimally invasive surgeries, which are office-based procedures, Botox, hyaluronic acid fillers, and lip augmentation, which are most commonly done cosmetic procedures. As far as the surgical part is concerned, liposuction, blepharoplasties, rhinoplasties, and breast implants comprise the top surgeries that are done. So something very specific to these cosmetic surgeries is that majority of these cases that are elective. So patient selection for us is very essential. These patients are self-paying. They are not covered by insurance. So they usually prefer that there is an office-based or an ambulatory procedure, which also in turn gives them a greater sense of privacy. When done in an office-based or an ambulatory surgery, there is a lesser psychological impact on these patients. One very important factor as far as cosmetic surgery is concerned is that these patients many a times do not inform at home. So they usually tend to come alone or with some friend. So we need to be very sure that there is a person available with them when undergoing a daycare surgery. Now, what are the principles that we take to decide for a daycare surgery? We should make sure that the surgery that is being performed has a minimal risk of major postoperative complications like hemorrhage, hemodynamic instability, or airway compromise. There should be no requirement for prolonged postoperative observation. The pain should be amendable to oral analgesics at discharge. Rapid resumption of normal functions in the sense of oral intake, mobilization should be possible. Anesthesia-related side effects should be minimal. And they should, as we discussed, they should have a responsible adult to accompany them and remain with them for 24 hours post-surgery. Geographical proximity to the hospital is desirable in case of readmissions that are needed. So coming to the preoperative evaluation, most of these patients are usually ASA grade 1 and 2. ASA grade 3 need to be optimized with reference to their hypertension, diabetes, thyroid, or coronary artery problems. Age is not specifically the only determining factor, but it is an important factor where we should remember elderly patients usually come with multiple comorbidities. They have a higher incidence of perioperative cardiovascular events, and even recovery may be slightly slower as compared to the other population. History of smoking or drug addiction is of importance in these patients. In short, about smoking, when patients are smoking, they have higher incidence of wound complications, infection, pulmonary complications, neurological events, and readmissions. So ideal is to quit smoking 4 to 8 weeks prior to surgery. The risk of respiratory complication definitely goes down. 3 to 4 weeks prior, wound healing is also better. And less than 4 weeks prior, they have similar rate of respiratory complications as current smokers. Similar is the recommendation for e-cigarettes, which is now becoming an increasing trend. Another category of patients that we need to give a special consideration to is the obese patients who tend to come for liposuctions or other cosmetic surgeries. So for daycare, we would take patients who are less than 40 BMI with comorbid conditions that are well controlled, and the surgery should be a low-risk cosmetic surgery. Screening methods commonly used is the stop bank questionnaire. OSA patients who are already using a positive airway pressure may be considered for daycare if their medical conditions are optimized, and they will be able to use these BiPAP devices in the immediate post-op period. Coming to the investigations, all routine investigations are recommended for these patients, that is CBC, creatinine, blood sugar levels, PT-INR, ECG, chest X-ray, sugars, and more specific investigations related to the age and associated comorbidities. Pregnancy testing for women in the reproductive age group is essential. Normal tests which are within the last 6 months may generally be acceptable as per the ASA recommendation. Important in the cosmetic patients is that these patients come with a certain set of expectations. So it is always better for them to be counseled prior. So scheduling an appointment for these patients 1 to 2 weeks prior will help reduce the anxiety as compared to doing it the evening prior. This visit also can be used for patient education, financial reviews, explaining the procedure to the patient, all the paperwork that needs to be done. This will in turn reduce the cancellations, no-show, or the substandard of perioperative care. Also important to tell these patients is that what they are supposed to expect from the surgical outcome, because these patients come with a certain set of ideas of how they are going to look post the surgery. So that is very essential. So consider the anesthesia goals for a daycare cosmetic surgery are to minimize the stress of these patients, make these patients comfortable, and have minimal anesthesia effect, residual effects on these patients. So the drugs that we should use should be rapid in onset and offset. They should have early return of cognition, and minimal PON, post of nausea, vomiting, dizziness, or drowsiness should be present in these patients. So standard intraoperative monitoring we would be using is pulse oximetry, non-invasive blood pressure, ECG, capnograph, temperature, and in addition, we also prefer to use the BIS monitor, which will help us to titrate the dosage of the anesthesia that we give, and in turn help in a rapid recovery. So the options that we have for anesthesia in daycare surgeries are a local anesthesia with or without sedation. So usually all the face procedures that are done, Botox injection, fillers, facial rejuvenation, they're all done under local anesthesia. They can also be supplemented with nerve blocks by the surgeon of supraorbital, intraorbital nerves, zygomatico-temporal and facial nerve. Hand surgeries also go under loco-regional. Labioplasty, vaginoplasties can be done under local, but because of patient apprehension, anxiety, usually they are supplemented with sedation. Smaller areas of liposuction can also be done under local anesthesia with maybe mild sedation, but it is important to ensure that local anesthesia is given adequately to the entire operating area, or the patient may end up receiving excess of sedation. Next form of anesthesia would be the TIVA, that is your total intravenous anesthesia. Preferred drug is propofol because of its rapid onset of action and recovery. It has a reliable hypnosis, and in addition, it also has anti-emetic properties. Use of opioids may be done as per recommendation if needed. We usually use fentanyl. And in TIVA, when you're giving fentanyl, we try to restrict it to giving it just 2 to 3 minutes prior to the incision. So that will help us reduce the total dose of opioid that is being used. Also, low dose ketamine, dexmedetomidine, they can be used as adjuvants, reducing the opioid consumption. Coming to general anesthesia, which is the usual preferred method, we do induction again with propofol because of its favorable qualities. Opioids like fentanyl can be used. Either we tube the patient or use an LMA with or without muscle relaxant, depending upon the surgery. Inhalational agent of choice, Sevo and desflurane, because of its recovery profile. So commonly how we proceed is that we use propofol for induction, followed by maintenance with inhalational agents. Muscle relaxants, preferably short-acting like Atra or Cis-Atra, but now again increasing trend of using rocuronium, vecuronium because of presence of Sugammadex. Spinal anesthesia can also be given for liposuctions of infraumbilical areas. So a low-dose spinal has to be used, but usually we have been using general anesthesia for most of these cases. Regional nerve blocks that can be used, they will prolong the analgesia, give a good quality of analgesia for a longer duration, reduce the requirement of analgesics, especially opioids in the postoperative period. So commonly where we use nerve blocks are for breast surgeries, where we use, there are case reports of PEX1 and PEX2, erector spinae block at the level of T5 for analgesia. Now, pain management becomes a very vital component of daycare surgery, because moderate to severe pain prior to discharge is going to extend the stay in the recovery room. It's going to affect the sleep quality of the patient, delay early mobilization, and thus impair the early return to normal function and work. So opioid analgesia related side effects such as sedation, respiratory depression, and nausea, vomiting can also lead to readmissions. So a multimodal approach to analgesia is very important. Commonly, what is used is the peripherally acting analgesics like paracetamol, NSAIDs, or coxyl inhibitors. Ketorolac is very commonly used in the NSAIDs. And along with that, local anesthesia for infiltration blocks are given. After that, the next step would be to use opioids. Fentanyl patch also very commonly being used now. These cosmetic surgery patients who usually come with a high risk of nausea, vomiting, mainly because of the risk factors that are involved. The young females, use of general anesthesia, where we are using inhalational nitrous oxide. We are also using the type of surgery that it is and the duration of the surgery. So all these factors add to the postoperative nausea, vomiting in these patients. So a combination that can be used for this prophylaxis is 5-HT3 antagonists like ondansetron, dolanosetron, granisetron, along with corticosteroids and proton pump inhibitors or H2 antagonists like pantoprazole and ranitidine. Second line of drug would be phenargan or droperidol to be used. We should minimize the use of opioids, nitrous oxide, and ketamine. In case of persistent PONV, then we can repeat the 5-HT3 antagonists like ondansetron 6 hourly. But however, there is no role of repeat steroids in such patients. Post-operative monitoring and discharge of patients. When discharging, we should make sure that there is no drowsiness. Patients are mobile without any dizziness, able to eat and drink, no excessive bleeding from the operative side. They are able to void, and all instructions that are given to the patient should be explained as well as given to them in writing. A responsible person should accompany them. Now we'll talk a little more about specifically the 3 or 4 the common surgeries that are there. That is special considerations for liposuction. So now when liposuction is used, there are multiple techniques that are used. That is wet technique, where 200 to 300 ml of fluid per area is injected. Super wet techniques, and the most commonly used is the tumescent technique, where 3 to 4 ml per ml of the aspirate plant is used. Advantage of tumescent anesthesia is that the blood loss is much lesser, that is less than 1% of the aspirated volume. A liposuction is mainly 2 types, either a large volume or a low volume liposuction. Large volume is greater than 5 liters of aspiration, and low volume is less than 5 liters of aspiration. So for daycare surgeries, only low volume liposuction should be taken. Commonly used solutions are the Klein solution or the Hunstad solution. The Hunstad solution with ringa lactate, lignocaine, and adrenaline is most commonly preferred. And something to remember about lignocaine when being used in this tumescent anesthesia is that it is a highly lipophilic drug. Even though the tumescent local anesthesia results in slow absorption from the subcutaneous tissue, adrenaline is delaying its absorption. 65 to 75% of lignocaine is still protein bound. So peak levels of this are measured at 8 to 18 hours after infiltration of this anesthesia. So in daycare surgeries, this is something that we need to be aware of, and hence low volume liposuctions only we should be doing. Lignocaine doses recommended are between 35 to 55 mg per kg. As per the American Society of Plastic Surgery, maximum dose of 35 mg per kg is recommended. Diluted lignocaine solutions of 0.05 to 0.1% are used. Ropivacaine and bupivacaine also have been used. They are longer acting local anesthetics, but they have a more cardiotoxic potential than lignocaine. However, the use of bupivacaine has not been recommended by the American Society of Plastic Surgeons, mainly because the duration of action of bupivacaine is marginally prolonged as compared to lignocaine with adrenaline, but the toxicity profile is much greater. Then something to remember about adrenaline that is added is that 0.25 to 1 mg per liter is the recommended dose. Total adrenaline use should not exceed 50 to 70 micrograms per kg to avoid the systemic side effects. Adrenaline will aid hemostasis and it will delay the absorption of local anesthetic, but it should be avoided in patients who have got hypothyroidism, severe hypertension, cardiac diseases, or peripheral vascular diseases. For liposuction, considerations should be given to, as we discussed, it should be a localized volumes, low volume of liposuction. Large volume liposuction will carry the risk of late manifestation of last and hemodynamic changes. So what we do is we usually prefer GA or sedation can be used. Midazolam, propofol, ketamine, and dexmedetomidine are the drugs of choice along with fentanyl. But to remember that primary analgesia to facilitate this procedure is always provided through the tumescent local anesthesia infiltration. Very important in liposuction that we want to know is how to manage the fluids. So to understand the total fluid intake in liposuction would be the intravenous fluid that we administer plus the volume of the tumescent anesthesia that is infiltrated. And the output is the urine output plus the aspirated volume, that is the fluid, blood, and fat. So the residual volume would be the difference between the total output and input. And the residual volume greater than 70 mg per kg increases the risk of hemodynamic instability. Complications rates of liposuction usually, though we say are less, we need to be aware of them. That is thromboembolism, hypothermia, fat embolism syndrome. Recently, in the last year or two, there was a case of a South Indian actress who passed away during a liposuction, and that was most likely because of a fat embolism. So hemodynamic changes, local anesthesia, toxicity, blood loss, which can be reduced with use of tumescent anesthesia and use of tranexamic acid, 10 mg per kg. And the other side effects that are there are pleural or lung injuries, ARDS, and anesthesia-related complications. Okay, so when talking about the fluid management, also we want to know how to replace fluids or how much fluid to give intravenous. So when a small volume liposuction, we prefer to give maintenance fluid, yes, but there need to be no replacement fluids. Whereas in a large volume liposuction, we are giving maintenance fluid plus 0.25 ml per ml of the aspirate above 4 liters. Balanced crystalloids are the fluids of choice. Okay, coming to rhinoplasties. In rhinoplasties, just the salient features that I would like to point out are that it is preferable to always secure the airway because we are sharing the airway with the surgeon. In short procedures, we can use LMA, either ProSeal, armored LMAs, or if endotracheal tubes are used, South Polar tubes or armored tubes are preferred. Now, throat packing has its conflicting views. If you go through a few articles, they will say that the dangers of throat pack not being removed prior to surgery, prior to extubation, outweigh the risk of aspiration or the blood trickling into the gastric, into the stomach. So if used, it is recommended that there should be at least one visual check. That is, either you keep one end of the throat pack out or you attach it to the endotracheal tube or put a marking on the patient. Or what we used to do is that you keep a marking on the flow meters with a micropore that there is a throat pack in place. Another important thing to remember in these rhinoplasty patients is that at the end of surgery, the nose is going to be packed. So the patient should be counseled prior to surgery and at extubation that they need to breathe from their mouth. So they should be awake at extubation. Important factor in rhinoplasties is that it's a very small area. Little bleeding also obscures the entire vision. So we always prefer to improve the surgical field and have a better hemostasis. Reverse Trendelenburg position, head up with 10 to 20 degrees. PEEP can increase venous congestion, but up to 5 centimeters is acceptable. Maintain normocapnia. Local infiltration with vasoconstrictors is also recommended. Use of tranexamic acid. Maintaining a mean arterial pressure of 55 to 65 is preferred, and TIVA has shown advantages over use of inhalational in rhinoplasties. Or use of dexmedetomidine propofol can also aid this. Coming to blepharoplasties, in blepharoplasties, minimization of swelling during intraoperative period and postoperative is very essential. So when there is insufficient pain management in these patients, there's increased blood pressure and the risk of postoperative ecchymosis, hematoma, swelling increase. So these surgeries usually are done under local with sedation preferably. We use midazolam, fentanyl, and dexmedetomidine commonly. Important anesthesia consideration for blepharoplasties is the occurrence of the oculocardiac reflex, which is seen almost in 25% of the blepharoplasty patients, and most commonly when it is being done under local anesthesia. So what are the causes of this oculocardiac vasovagal response? Is first, the anxiety and fear of getting operated near the eyes. Second is olfactory irritation of the smell because of the tissue being burnt so close to the area of olfaction, leading to sympathetic activation and bradycardia. Or via the trigeminal, the oculocardiac reflex because of traction on the eyeballs and even tug on the ocular pad fat. So the best treatment is to release the tension on the muscles. Along with that, leg raising, administration of fluids, atropine or glyco as per need, and in case of a severe bradycardia or asystole, giving CPR. The last one that we are going to discuss is about the breast surgeries, which are very common, most common of which is the breast augmentation, which can be done either by placement of implants and less commonly through fat transfer. Implant placement is mainly in two forms, either submuscular under the pectoralis or subglandular. Our goals are adequate pain management in these patients and reducing PONV. So anesthesia techniques that we commonly employ are a general anesthesia with LMA, with or without muscle relaxants, local anesthesia with adequate sedation, and for analgesia, intercostal nerve blocks, as we discussed, PEX block or the erector spinae block can also be done. So to conclude, we are going to, when considering cosmetic surgeons, patients for daycare surgeries, we want to provide safe and precise anesthesia with minimal post-operative complications and readmission rates. Successful conduct of a case in ambulatory setting needs a dedicated team. There should be a close coordination between the surgeon, the anesthetist, and all the staff involved in this ambulatory care of the patient to give the patient the best cosmetic result that we can. Thank you. I would also like to thank BSA for giving me a chance to talk here at this platform today.
Thank you so much, ma'am, for this extraordinary lecture. I would now like to call Dr. Alpesh Bhanushali for the next lecture on surgery for IVF, anesthesia for IVF surgery. He is a freelance anesthesiologist in Mumbai with major interests in high-risk obstetrics and fever sedation and regional anesthesia. He has won many awards, one in particular being he was the winner of last year's debate at the third Yuva Mahakon that was held in Nagpur. Over to you, sir.
Am I audible?
Yes, sir.
Yeah.
Yes.
Let me share my screen. First and foremost, I would like to thank my heartfelt gratitude to ISA Borivali for providing me with this opportunity to express my views on a topic that is very close to me. I have no financial disclosure to make. Every effort has been made to ensure that the information contained in this presentation is correct and up to date. We will be covering this topic under the following heading: what are the IVF procedures, IVF setup, challenges we face, anesthesia management, complication and their management, tips that I have learned over the years, and then the summary. Firstly, IVF procedure. IVF procedure encompasses a vast variety of procedure, but for us as an anesthesiologist, we are usually called to administer anesthesia for the following procedures, which is ovum pickup, embryo transfer, TESA or testicular aspiration, or testicular biopsy, and IUI, which is intrauterine insemination procedures. Ovum pickup previously used to be done via the transabdominal laparoscopic route, but nowadays it is typically performed via the transvaginal route under ultrasound guidance using a vaginal probe. This is the pictorial depiction of how ovum pickup is being done. This is
Sorry
the
to-
same pictorial
sorry to interrupt,
representation.
Can you please make it full screen?
Hello?
Can you please make your presentation full screen?
Sorry?
Your presentation is not full screen.
Screen full screen करो, full screen.
Just a second. Is it
Yeah.
visible now?
Yes, perfect.
Yes,
Yes, sir. Thank you.
Yeah, so this is the depiction how ovum pickup is done via the transvaginal route using the transvaginal probe. Similarly, this is a pictorial depiction how embryo transfer is being done. This is how TESA is done. We have TESA is just the aspiration where 20 gauge needle is put and we aspirate the cervical fluid, and testicular biopsy is an incision based procedure. So IVF setup, procedure room. There is generally a procedure room where most of the ovum pickup and other procedures are being done. Attached to the procedure room is an embryology lab. In between the two, there is a slight window where they pass the body fluid. So there is no delay in giving the fluid to the embryologist. And there is generally an andrology lab. What precautions we have to take is we are not allowed to have any cosmetic, no perfume or deo, as it increases the VOCs. VOCs means the volatile organic compounds. No alcohol or iodine-based solutions are used in IVF lab. Regarding the use of mobile phone, is better to avoid taking mobile in the IVF lab, as radiation can alter the result of IVF. Now, the challenges that we face is firstly the location of the lab. As this is an isolated, so it's mainly at one corner of an hospital where you have to pass to the two doors to keep it as sterile as possible. So the location is a little bit, you can say, distant. So in case of emergency, getting an help takes little time, and there is limited movements, as limited people are allowed in IVF lab, because more people will lead to more of CO2, and which will in turn increase the VOCs and it can hamper the IVF result. Now, lastly, we will be talking upon the patient profile, which is very important for our anesthesia management. This is a table where we need to see that most of the patient who comes for IVF generally have some kind of systemic illness. And that systemic illness is important for us because it has some of the anesthesia consideration. Likewise, the most common cause being the polycystic ovarian syndrome. So the anesthesia consideration are that such patients who have PCOS, they are generally have high body mass, they have insulin resistance, they have diabetes, and they have some of the GI upset, which need to be. Likewise, second most common cause is the pelvic inflammatory disease. So they have acute pain, and such kind of patient during sedation also they require very deep sedation because their pain tolerance is very less. And lastly, as IVF now has been increasing and has become most technically advanced and safe also. So more and more people are opting for IVF. Majorly the advanced age are now coming for the IVF procedures. So with advanced age, they generally have their systemic illness in the form of hypertension and diabetes, which we need to keep an anesthesia management now. We'll be covering under preoperative checkup, which will be the same as with the which we do in other case. There is no difference in that. We need to check the consent on the day of procedure. Generally, being and daycare surgery, the patient are usually admitted just 2 hours or 3 hours prior to the procedure. So you need to check the consent. IV access has been established. Regarding IV, the attachment of an IV fluid is little bit controversial. You can do it if a patient is prolonged fasting, but we generally keep patient fasting for just 6 hours. So generally we don't require any IV fluid to be given in the pre-op area. Pre-medication is given in the form of Onden and PAN 40, and then induction and recovery are done. I won't be talking much about the various drug as it has been already covered, not the doses. Just we will look at the significance, what various anesthesia drug do to the IVF procedures. These are the PAC points which you need to be keep an eye on, especially the fasting guidelines. And also we need to double cross check whether they are accompanied by a person or not. Sometimes some patient they come without any accompanying person, so that should be kept in mind. So what is the ideal feature of an anesthesia technique for the procedure of IVF? The technique should be able to provide a safe, effective, and adequate analgesia. It should be rapidly onset, and the recovery should be fast without no or minimal effect on the oocytes. There should be no change in the follicular fluid and the pH that has been aspirated, and there should be no effect on the fertilization or the pregnancy rate. So various anesthesia techniques can be done for ovum pickup or IVF procedures, which include from monitored anesthesia care to the alternative techniques like TENS and acupressure have been mentioned in the literature. But we will be seeing the practical which we generally use. These are the advantages and disadvantages of the different techniques which are used in IVF procedure. Sedation with monitor anesthesia care is most commonly used. The advantages are it is easy to administer, patient maintains his own airway, and there is faster recovery time. The disadvantage being that the patient might experience some discomfort during the procedure and may have some limb movements, which is it will during the procedure, if there is involuntary movement, there can be chances of any vascular injury and so. General anesthesia, the advantages are that the airway has been secured by us, there is no limb movement, and there is no discomfort to the patient during the procedure. The disadvantage being that there are high chance of post-operative nausea and vomiting, and there is prolonged recovery time. Regional anesthesia, the advantages being that patient maintains his own airway, there is no limb movement, and there is no discomfort. The disadvantage being that it delayed ambulation and then urinary retention is one of the factors. That's it. So these are some of the literatures which has been done on various drugs. Firstly, benzodiazepine and on the IVF outcome. Midazolam has been considered the safest sedation drug to be used as it is not secreted in the follicular fluid. Regarding ketamine, is not secreted in the follicular fluid as such, but it has been observed that it increases the prolactin and the beta endorphin plasma level, which invariably affect the IVF rates. So generally, you should keep ketamine as the last choice. Regarding GA and IVF outcome, GA has been found to affect the IVF pregnancy rate, be it with O2, nitrous, and various halogenated agents that we use. They hamper the IVF success rate significantly. So they should be avoided or should be kept as a last choice. This is again regarding the volatile halogenated agents. All the study mostly shows that there is some kind of IVF hampering in the results. This is regarding the spinal or the epidural anesthesia and the outcome. The safest, if you ask me which is the safest kind of anesthesia and which doesn't have any effect on the IVF outcome. So regional anesthesia by literature has been shown that it is the most safest than MAC and everything. In MAC, compared to MAC, the plus point is that the patient is very comfortable. There's no discomfort, though no involuntary movement and all. But IVF is now done as an ambulatory procedures. So giving a spinal anesthesia for a IVF procedure seems to be very overkill. And mostly spinal anesthesia is not acceptable by patient also routinely now. NSAIDs have been considered as safe and you can give them as pre-op also. There's no issue in that. Now the adverse event that can occur during your MAC sedation or TIVA or your GA. Firstly, during MAC sedation or TIVA, there can be prolonged apnea. This happens mainly when you give the propofol as a bolus injection or in large dose. So the remedy is just gentle stimulation by lifting the jaw thrust can stimulate the respiration, and then this apnea can be. In case after giving jaw thrust also patient is under apnea, then you can just manually ventilate with mask. Inadequate pain relief. Mostly this is seen in patient of polycystic ovarian disease or the patient who have pelvic inflammatory diseases or endometriosis. So in this, you need to deepen the anesthesia pain by giving the additional doses of propofol. Excessive movement is again due to the inadequate depth of anesthesia. Spasm also is because of the inadequate depth of anesthesia. So you need to um, maintain the adequate depth of anesthesia. The point to be considered here is that once you induce your patient for IVF procedure by giving the initial bolus dose, then you don't wait for the patient to come out or to move. Just give some small doses like 1 ml, 2 ml of propofol in between so that it maintains that deep level of anesthesia and there are very less chance of patient undergoing spasm. Vasovagal has been found because the cervix has been found that there is a paracervical ganglion and it is distally innervated by the vagus nerve. So you need to keep a watch on vasovagal. Nowadays, generally, literature says that there is no need of giving glycopyrrolate in cases and all, in sedation and all. But I would recommend that you give glycopyrrolate to prevent this vasovagal. It's better to prevent it than to treat vasovagal. Secondly, now we will talk about these procedure-specific complications. So in ovum pickup, ovarian hyperstimulation syndrome is one of the complications which can occur. So in this, initially patient complains of abdominal discomfort due to the increase in size of the follicles, and this may be followed by the nausea, vomiting, and diarrhea. If not treated properly, or if it's advances to severe form, so it will be accompanied by ascites, pleural effusion, hypovolemia, oliguria, and shock. So electrolyte imbalance are common in case of severe disease, and thromboembolism is very dreadful, and you can say it increases the mortality also in such cases. So how you can suspect if patient, if there is abdominal pain and shortness of breath and vomiting, so you should suspect ovarian hyperstimulation syndrome. Mild cases can be managed with hydration and symptomatic treatment. In severe cases, intensive care management is required. Now, we'll coming about the embryo transfer and some of the significant points in required usually in patients who are very anxious or who have difficult in cervical negotiation. So whenever you are called for, keep in mind that patient has a very low pain threshold and will require very deep sedation. So you should be prepared regarding that. And providing good analgesia is a key that will reduce your sedation dosage. TISA or testicular biopsy, you should always give glycopyrrolate, give good local block, because this is one of the procedure where there are a high chance of vasovagal. Either go for local, completely local or completely awake patient with block, or you give complete GA. There should you shouldn't be giving some sedation or nothing in between. In case if patients are very difficult airway, very obese and all, prefer saddle anesthesia in such cases. So when you will discharge such patient, IVF patient, when their vitals are stable, there is minimal pain, nausea and vomiting, they are able to pass urine, they are able to ambulate without any assistance. They should be oriented to time, place and person. They should have a responsible escort with them, and they should be instructed when to contact in emergencies. Now coming to the tips or how I do it, I always give glycopyrrolate as a pre-med. I prefer TIVA. I don't use any inhalational anesthesia for any of the procedures. I always keep the patient very deep. That may lead to sometimes to tongue fall or airway compromise, which can be easily handled by your oral or nasal airway and some stimulation, which I call it hands of airway technique, which I generally use, and it serves the purpose and patients are comfortable in that. As I mentioned, the key is to maintain that deep state throughout the procedure. Also keep your anesthesia duration short. Don't give initially before positioning. Don't start giving propofol and during positioning and all. Once the surgeon gloves, at that time start your propofol injection so that it's very less secreted in the follicular fluid and can increase the IVF success rate. You can give midazolam before positioning in very highly anxious patient. One of the most important point I want to tell regarding the daycare surgery is key. Once the procedure is done and once patient is little bit out of anesthesia and obeying command and all, I don't give O2 supplement O2 on the table only at all, because shifting the patient after the procedure from table to trolley and to the recovery room takes around 5 minutes. So if there are any chance of tongue fall or any airway complication, so the saturation probe is there and you can catch up. Supplying supplemental oxygen can little mask that initial drop of saturation and all. And lastly, you should have all your equipment and drugs standby in case general anesthesia is required. So summary, the anesthesiologists are faced with the challenges of the technique that elevate the patient and anxiety with adequate analgesia. And at the time, it shouldn't be detrimental to the IVF success rate. Always pay attention to the comorbidities and the mental stress that the patient is taking, because these infertility patients are already in mental agony and all. Lastly, the anesthesia should be used for the shortest duration possible. Thank you. These are some of the references. Thank you.
Thank you so much, sir. This has been a very informative and detailed lecture from your side. I must compliment all our speakers today, since I can hardly see any questions in the chat box. The presentations have been quite precise and detailed. Thank you so much to all the speakers. I would also like to send my gratitude to all our 4 panelists. I would like to introduce them to you. I would like to first introduce Dr. Alpesh Jogani. Can I have his slide, please? Thank you so much. He has done his MDS in pediatric and preventive dentistry. He is internationally certified in myofunctional orthodontics from the USA. He has won the award for the best oral presentation at ISPPD in 2011. He has a past teaching experience of over 8 years, and at present he has an experience of performing precise dental procedures on children for more than 15 years. He has an exclusive pediatric dental clinic with special emphasis on airway and sleep dentistry, Dr. Vivek Jogani. We also have Dr. Siddharth Kesarvani with us. He has a fellowship in, yes, thanks, back please, yeah, thank you. He has a fellowship in pediatric strabismus and neuro-ophthalmology. He has founded the Mariam Hyman Children Eye Center at LV Prasad Eye Institute at Bhubaneswar, which he headed for several years. He presently runs the JNR Eye Care and Squint Clinic at Borivali in Mumbai. He has several publications in renowned journals to his name that are widely acknowledged in the world of pediatric ophthalmology. Welcome, sir. I would now like to introduce Dr. Ajay I'm so sorry. Dr. Ajay Haryani. Can I have his slide, please? Thank you so much. Apologies for the pronunciation mistake. He is a cosmetic and laser surgeon with a private practice experience of over 28 years. He has been the past president of Association of Medical Consultants, past president and trustee of Malad Medical Association, with a Lifetime Achievement Award out there for the same. He has been invited as faculty in many national and international conferences for several operative workshops on liposuction, breast reduction or augmentation, and laser surgery. Welcome, Dr. Ajay, sir. And lastly, I would like to introduce Dr. Rupa Saraugi. Thank you so much. Yeah. She's an alumni of State GS and KEM Medical Colleges. She's a consultant obstetrician and gynecologist at Saraugi Maternity and General Hospital at Malad. She is also affiliated with top hospitals such as Surya and Cloud9 as visiting consultant. She is the co-director at Iris IVF Center. She has received awards like DISA Memorial Award and late Durga Ramdas Sadle Memorial Award. Her special interests include high-risk obstetrics and reproductive endocrinology. Thank you so much for being with us today. I would like to start the question and answer session with our first topic, dental rehabilitation. The questions will be directed to Gauri ma'am and Vivek sir. Just a minute, please. Yeah. Okay. So my first question is to Dr. Vivek sir. Hello. Am I audible?
Yes, you are.
Yeah, thank you. My first question is directed to Dr. Vivek sir. What type of anesthesia should be preferred for dental procedures from a surgeon point of view? Would you prefer conscious sedation or a full GA with a secured airway? Dr. Vivek? Hello?
Vivek sir, just I think he left by mistake. He'll have to join again.
We could wait for a couple of minutes, or would you want me to start with the plastic surgery, the cosmetic surgery?
Gauri ma'am can answer the question actually.
Gauri ma'am, what would your point of view be with respect to this? What kind of anesthesia would be preferred for dental procedures, conscious sedation or full GA with a secured airway?
Personally, as I've mentioned in my PPT, that it always depends upon the age of the patient, the underlying syndrome, systemic conditions, and obviously the procedure, what is the duration of the procedure, how painful and how extensive it is. So mostly the conscious sedation will go for patients who are generally teenagers or adults.
I apologize, ma'am. You're not
Now
audible
can you
right now.
now can you hear? Now can you hear me?
Yes, much better. Thank you so much.
So it is. Can I repeat like whatever I said?
Yes, please, ma'am. Thank you.
As I mentioned in my PPT, that it always depends upon the age of the patient, the underlying syndrome, systemic condition, the procedure, the duration of the procedure, how extensive it is, how painful it is. So generally, the conscious sedation I mentioned is that generally patients who are not cooperative but counselable, like teenagers or adults or adolescents who are extremely phobic, apprehensive about the procedure, but at the same time we can counsel them, make them comfortable for it, and not procedures which are generally lasting more than half an hour, 45 minutes, painful procedures where LA is contraindicated. We'll avoid those. Those patients will definitely go for GA. The preschool children, then procedures lasting more than an hour, more extensive procedures, definitely go for GA and not conscious sedation. That is what I think of.
And what about minor procedures and operation theater versus dental chair anesthesia? What would you recommend, even for minor procedures?
See, minor procedures, like many of the dental clinics, as you know, that they're not equipped with proper monitoring setups. The staff is not trained, which is very important. Then most of the times the anesthesia medications are not available. The places are definitely not registered for, they don't have license to use the anesthesia medication, and the generator backup is not there. So these are the important things. I will definitely avoid such procedures in dental clinics. I'll definitely take these patients in the OT setups, not
Thank
the
you so much,
dental
ma'am.
clinics.
Understandably. Thank you so much, ma'am. Tejveer sir, would you like to ask the next question, please?
Yes, ma'am. What is your take on the use of opioids in these dental surgeries? And another one is, have you ever used or suggested use of melatonin as pre-medication in children?
So the opioids, we can definitely go opioid free with the availability of medications like ketamine, dexmedetomidine. Uh, then for pain reliefs, we can definitely go for paracetamols, NSAIDs, local infiltrations. Opioids are will use when the LAs are contraindicated, like patients allergic to LA, or when the LA is contraindicated because of the underlying presence of abscesses. So there we can use opioids. If the procedures are severely painful, extensive, for general anesthesia with endotracheal intubations, we can think of giving opioids in the dosages like 1 to 2 micrograms per kg, which will cause minimum PONV and constipations.
And ma'am, about melatonin, any experience
So
or any
melatonin,
recommendation?
I have personally speaking, I've never used melatonin as a pre-medication. I've used pre-medication like midazolams, ketamines, dexmedetomidine, clonidine. When we have got this better options, so I have definitely not used melatonin in pediatric patients.
Ma'am, there was one question for actually Dr. Vivek Jogani. Unfortunately, he's not able to join for some reason. We wanted to ask how many root canal treatments they should be allowed in one sitting in a child. Is there any limit or
No,
anything?
sir. If in a children, we go for a general anesthesia with endotracheal intubation and securing airway. So they can do as many root canals they want in the same sitting, because the full mouth dental rehab is also done in patients under general anesthesia. In conscious
Dr.
sedation
Vivek
to
has joined, huh?
Thank
Dr.
you, sir.
Vivek has joined us.
Thank you. Welcome, Vivek, sir.
Sorry, some light had flickered over here last moment.
Yeah, sir. Actually, I just asked that question. We wanted to know, is there any limit on how many root canal treatments you would do in one sitting in a child? Or like, would you prefer uh, full mouth rehabilitation in patient just to avoid frequent visits, even though we are talking of daycare?
Okay, so when we talk about full mouth rehabilitations under general anesthesia, there's no restriction. Am I audible?
Yes, sir.
Yes,
Very
sir.
well.
Yeah. So when it comes to dental treatment, especially full mouth oral rehabilitations under general anesthesia, there is no restriction as to how many root canals can be performed in a child. There or in any individual. It depends on what the procedure is. So whether it's 2 root canals or 10 root canals, any number of root canals is fine.
Okay, sir. Dr. Smriti, would you like to ask a chat box question?
Oh, yes, I would actually like to repeat the question that I had for Dr. Vivek before he had. I would like to know your point of view with respect to what type of anesthesia would the surgeon prefer for dental procedures. Would you prefer conscious sedation as a dental surgeon, or would you prefer a full GA with a secured airway?
Definitely full GA with a secured airway.
Thank you, sir.
Yeah.
I guess we're done with our questions on dental surgery. The presentations have been so amazing that
Yeah, Dr. Gauri
questions
covered
are
quite a good
quite
part.
yes, sir. We would now move on to questions related to pediatric ophthalmic surgery. I would request all the members of the audience, in case they have any other questions related to either of these topics, you could please message in the chat box, and we will take them up at a later time during this session. There is one question, sorry, I would like to take this up right now. Dr. Kunal has asked, since pediatric patients have their first exposure to anesthesia medication, how important is it to give LA test doses? Dr. Gauri, would you like to answer this one, ma'am?
Yes, Smriti. What was the question?
Repeating the question. Since pediatric patients have their first exposure to anesthesia medication,
First exposure to anesthesia medication? I can't see that question in the chat box.
Ma'am, since these patients will have the first exposure to anesthesia meds, how
Mhm.
important is it to give a LA test dose in those children?
So we never give LA test to pediatric patients. Some hospitals policies they give LA test dose, but I don't recommend giving LA test dose. It depends upon the hospital and individual pediatrician. As far as like I don't recommend giving LA test dose for pediatric patients.
Okay, ma'am. We had one, there was one case which I wanted to ask you. We had an adult Down syndrome patient, 38-year-old, for full mouth rehabilitation under GA. We needed 4 people to hold him down just to secure the IV line because it was not possible to hold the mask on them. So, do you have any uh, advice for such kind of patients who are like mental age of 8 to 9 years and physically very strong? How do we handle them? Like, it's not easy to handle them like kids.
These patients we can give either IM ketamine in the preoperative area because
Okay.
giving oral dosages of oral or nasal midazolam, the volume is going to be very high. Or at this patients we can ask parents to accompany them in the operation theater. That makes them little more comfortable and easy for us for the pre-medicate them or induce them. So I feel IM ketamine parental presence will make a difference.
Tej, can I intervene?
Please, sir. Please.
I've done a couple of few cases with Dr. Vivek, similar special kids who are overweight, and but one thing is there, they are attached to at least one person in the family who has been taking extreme good care of him, and they listen to him or her.
Yes, sir. Yes.
So if that such a person accompanies them, they become very easy to handle. No, they allow taking an IV, and after that we can manage it. But that one person, one point contact, the child who's taking care of that person for years, is very important. I think Dr. Vivek will agree.
Yes, definitely. Not that definitely with one of the family member or parent or one stern instruction, and that moment is sufficient most of the times. So yeah, it is not that it wasn't ever possible to ship them to the OT without any pre-medication. Time consuming, but definitely manageable.
Thank you, sir. Smriti?
Tejveer sir, yes
Yeah.
sir. Tejveer sir, one question that Dr. Shilpa had asked chat box which we missed earlier. Can we allow these patients to be given on GA on an OPD basis? Dr. Gauri, since we've established that GA is the form anesthesia of choice to these patients, should GA be given on an OPD basis, or would you like an overnight admission in such cases?
For GA, we can see these cases are generally taken as a first case on your list. So, and the dental full dental rehab doesn't take more than 3 to 4 hours. So, if we take these cases in the morning, then we definitely finish them by 12 o'clock, 1 o'clock. And by the time the patient has started taking orals, it is already 6, 7. So, we can definitely discharge these patients on the same day. Even with the patients who have received general anesthesia, not only the conscious sedation, we can definitely discharge them on the same day.
And today with better drugs which are easily metabolized, I think our fasting guidelines also coming down, post-operative fasting. I think 6 to 7 hours post general anesthesia observation is good enough.
Thank you, sir.
Smriti, carry on with the next.
Yes, sir. So we move on to questions related to pediatric ophthalmic surgery. We have so there is a question related to the effects of IOP on of the other factors apart from the drug? As in, apart from the anesthetic medications, are there any other factors that affect the intraocular pressure?
Question is to me, Kriti, or Siddharth?
Yes, so you can answer it. Thank you, sir.
So even a raised CO2 can have effect on your intraocular pressures. But as I mentioned in the lecture, I think Siddharth can shed more light on this. Intraocular pressure generally for surgeries like cataract, etc., they can easily control the intraocular pressure. So most of the times it is not a challenge for us. A raised very high CO2 sometimes can be detrimental to the intraocular pressure. A low O2 also can be detrimental. It can cause like a drop in the intraocular pressure. So you have to always take care of your oxygen and carbon dioxide, etc. The ETCO2 should not rise a lot during these procedures. Sometimes during spontaneous respiration, that is the reason one thing I said was we avoid opioids, because once you give opioids, the ETCO2 tends to rise a lot. If you are able to avoid opioids and maintain on spontaneous respiration, your ETCO2 will always remain under control. So if the ETCO2 is rising a lot, many times you have to control the ventilation to maintain the ETCO2 within the normal limits.
What about temperature, sir?
Even hypothermia should be avoided. Like hypothermia, all the homeostasis should be maintained. Basically, anything that disturbs the homeostasis will affect your intraocular pressures. So all your hypothermia, all your CO2s, everything, all parameters should be within your normal limits.
Thank you, sir. Question to Dr. Siddharth. What are the anesthesia? What have you ever used chemotherapy for retinoblastoma? For example, melphalan, the agent melphalan. Have you ever used melphalan in any of your patients?
I don't treat retinoblastoma. I'm sorry, I can't answer that.
Thank you, sir. Any idea, Ankit sir, what are the anesthesia considerations for intraarterial chemotherapy with melphalan? Have you ever encountered such cases, Ankit sir?
Yeah, we have encountered, but these are definitely not daycare procedures. I would prefer to do them in proper hospital setups. So sometimes you have to give heparin. You are giving they inject melphalan in the retinal artery, etc. So sometimes you have to give heparin, and many times after whatever the side effects of heparin, etc., has to be taken care of. So I have very limited experience with the use of melphalan. One or two cases I have definitely done, and I do remember like you have to give heparin for those kinds of cases.
Thank you, sir.
Ankit sir, I would like to just say that although we had prepared a lot of questions for you, as you've covered most of them in your talk, I would still like you to, just emphasize what patient should not be done as daycare in patient selection or maybe procedure selection.
So very small babies, less than 1 year, generally you can do under daycare, but they have to be done by experienced people. Syndromic children, especially some children like mucopolysaccharidosis, they should not be touched in daycare procedures. Down syndrome, etc., who are well managed, well maintained, no cardiac issues, you can attempt under daycare procedures. So basically, it's syndromic children and very small babies that you have to avoid in daycare procedures.
Thank you, sir. So one question to Dr. Siddharth. Sir, have you encountered any cases of severe oculogyric crisis? We always read about it and it kind of scares us whether to give higher dose of atropine or glycopyrrolate just to prevent that.
You mean oculocardiac reflex?
Yes, sir.
Yeah, so I had one case of a adolescent child who went into oculocardiac reflex and he didn't recover. So his pulse became 0 and all. Then we had to give him CPR and then we could revive him. But that was one of incidents. I mean, most of the oculocardiac reflexes, the moment you leave the muscle, in some few seconds, the pulse rate comes back. And if it happening again and again, it's usually the first time when you hold the muscle, it is most prominent. Second time when you hold the muscle, it is not that severe. But if it keeps happening, then some amount of infiltrative block near the muscle that takes care of the reflex. So very difficult to predict in whom how bad it will be, but it's extremely rare. I mean, I have seen uh, a very severe case only once in my 17 years, so it's very rare. Yeah.
Thank you, sir. Ankit sir, just once
One
again the
question from
same.
one question from me,
Yes,
Dr.
sir.
Siddharth. Nowadays, with a lot of things being done in the topical anesthesia, there are few anesthetists who are doing exclusive ophthalmic anesthesia. So, do you prefer giving the blocks yourself if you require to, or you are comfortable with the anesthetist giving the blocks?
No, I give my blocks. I am not comfortable with anybody else giving. Especially in a child, I would give the block myself.
Okay.
Because as Ankit pointed out, there's very little space in the orbit of a child. So, and the sclera is very thin and very elastic, so very easy to perforate the eye. So only somebody who's giving blocks, hundreds and thousands of blocks should venture into a pediatric orbit.
Thank you, sir. Ankit sir, just once again, is there a separate dose for atropine or glycopyrrolate in these kids compared to what we normally think of for
No, it's the same
bradycardia?
dose, and generally I would like to add, like, I don't give it as a pre-medication. Like glycopyrrolate, nowadays we don't use very routinely. So it is not that you have to give glycopyrrolate in all the cases. Most of the times we tell or inform the surgeon that bradycardia is happening, and once they leave the muscle, most of the times the pulse rate will come back. So as a pre-medicant, we hardly ever use, only on those refractory cases, or sometimes even after leaving the muscle, the bradycardia persists, only then we give glycopyrrolate. So a routine pre-medication of glycopyrrolate is not recommended.
Thank you, sir. Smriti, please continue.
So I would like to move on to the next set of questions for the next topic on cosmetic surgery. This is a question directed to Dr. Jaisal. Jaisal ma'am, is there a higher risk of post-operative nausea, vomiting in cosmetic surgery cases? Would you consider that? Have you experienced that in your practice?
Yeah. So as far as postoperative nausea, vomiting is concerned, these patients do have an increased factor, especially because they're usually young patients. They have a lot of apprehension. They come with a certain idea fixed in their mind, so they are very worried. And so in such patients, we usually tend to give GA sedation, where we are using opioids. Sometimes we're using nitrous oxide. So all these multiple factors, they predispose them to post-operative nausea, vomiting. So as a protocol, we try to give them a good antacid prophylaxis, antiemetics, and tide over the crisis, if possible.
Thank you, ma'am. I would actually like to ask the next question to Dr. Ajay as well as Dr. Jaisal, ma'am. Procedures such as rhytidoplasty, that is facelift, and abdominoplasty, in which we are expecting some good amount of pain that the patient might experience. Would you qualify these cases as daycare? What would your preference be? Would you want to admit these patients, or would you want them to be as daycare surgery to be discharged in the evening?
Basically, the cases are abdominoplasty. Sometimes you have to put a drain. So I prefer to give the patient overnight.
Okay, sir.
And second thing, this is a facelift. There's a lot of swelling in the face. The ecchymosis is there. So better to give them and give them ice packs post-operative period. So better to keep them in the overnight. I do not prefer the daycare for them.
Thank you, sir. So what is your opinion about combining two procedures in the same setting with respect to the duration of the surgery, with respect to DVT prophylaxis, DVT risk? Would you consider combining two surgeries in one? And if yes, would that be a daycare surgery, or would you keep for observation overnight?
It depends upon what type of surgery you're doing. Suppose you're doing two area liposuction, suppose you're doing abdomen and thigh, then okay, it's a daycare, you can put it. Or if you're doing a combination procedure of lipoabdominoplasty with breast reduction or something, then definitely it's not ambulatory surgery. And then depending on what, I mean, cases with them. Suppose I'm doing a anterior as well as posterior, like abdomen liposuction as well as buttock liposuction. I have to turn the patient and everything. That's a little extra duration. So I prefer to keep the patient overnight.
Thank you, sir. Jason, ma'am, what would be the anesthesia considerations or a change in anesthesia requirements if two procedures are to be combined in the same sitting?
If to first it again, as I said, it would depend on what two procedures they are combining and whether we would be doing that in daycare. As a rule, I think rhinoplasty combined with any surgery we will avoid. We would not want to do rhino with any other combined surgery. If there are two minor surgeries, depending again upon the site, I would decide on that, but most likely a general anesthesia would be preferable, because if there's a change of position, if it's two extremities, upper and lower, then I don't want to give spinal, then supplement sedation. I have to go for a straightforward general.
And what about DVT prophylaxis, ma'am? Whether combining, whether not combining, any routine, should we routinely give DVT prophylaxis?
Yes. So for all surgeries extending beyond 1 hour approximately, we are using calf compressions for most of the patients.
Basically, I'll just see the patient's lifestyle. Suppose a morbid patient, having obesity and all that. If he's having a little sedentary lifestyle, or the patient, a lot of, tourism patient, they're coming from abroad and traveled the previous for about 17, 18 hours. Then I prefer that to get a DVT prophylaxis, or a patient has taken a history of estrogen. Most of the females have the problem with delaying the periods. They take a lot of hormone preparations. In that patient, it's better to take DVT prophylaxis.
So what kind of DVT prophylaxis would you prefer in such cases? Would you prefer the stocking or the physical method, or would you prefer the injectable low molecular weight heparin?
No, I prefer a compressible DVT stockinets in the patient. And second thing, whenever doing a liposuction, I tell my staff to go on squeezing the calf in between, That's the movements. That's the better thing.
Thank you, sir. Also, Jason ma'am, the question directed to you. Are there any herbs or foods that are usually taken by the patient, for example, for anti-aging or weight loss, like the ginseng and the ginkgo and all of that? Are there, or do you think all of these need to be avoided perioperatively?
Yeah, so lots of patients do come with history of wanting weight loss, and they are on all of these herbal medications. So if you go through literature, it does say that it increases chances of bleeding. So in order to avoid that, we always make it a rule to stop those before a surgery.
Do you have any examples of such herbal?
By the time they come to us, all the medicines already stopped. So I will not be able to tell you the specific names.
Sometimes when I'm doing facelift surgery, we ask them whether he had papaya. Don't have papaya previous night, or have vitamin E supplements. That's very important. Even some of the salicylic, products containing salicylates, like almonds, apricots, they are for the clotting mechanism sometimes. So better tell them avoid. Best is to have fresh fruit before surgery. That's the best thing. The day before surgery.
Dr. Haryani, most of your cosmetic patients are high profile, having a very wayward lifestyle, smokers, substance abuse. They deny telling us these histories. So how to go about it? Just today morning, I got a call from an anesthetist. The patient she was supposed to take, and patient told her that he was smelling of cigarette smoke, and when she asked him, he said, "I just half an hour back have smoked and come." So you also
basically I have my pre-op checklist, and plus when the patient comes for consultation, there's a checklist, and that's just everything mentioned. See, they have to sign that papers, and there's history of smoking, alcohol, and drug abuse, everything is there. Even the female patient's LMP is there. So they have to checklist, they have to sign it. This is in my OPD. When they come for surgery also, they have to. See, that's something they hide. We can't, help it. But then everything is documented. See, whatever is documented is occurred. I put it that way. If you don't document, the patient he denies.
Okay. Question to Jaisal. Suppose you get such a patient who has smoked in the morning, and Dr. Ajay wants to do some daycare procedure in him, where you have to give GA. So what would you do?
So these are highly elective cases. So I think if the patient has just smoked prior to surgery, I would prefer not to take up that patient for anesthesia.
Okay.
I agree with Jason in that case. I would also not do the surgery.
I know Dr. Ajay for last 30 years, and he will also agree with you. But there are few people who will say, "Madam करो ना, कुछ नहीं होता है,
I'll tell you. See,
चल
I'll
भाग
tell you
जाएगा."
one thing. No, I mean, tell you, no one is going to give a medal while doing surgery, okay? In this court of law,
Absolutely.
I mean, yeah. So don't do heroic things in life. Peaceful, you can easily postpone surgery, and if you do that thing, the patient is definitely going to come back to you because he knows that the doctor is going to take care of him.
This is there's a question for you in the chat box.
Yes, sir.
For this post-operative nausea vomiting, in spite of giving Dexa and 5-HT3 antagonist, have you ever used that injection sultarant, which is levosulfuron, which is a dopamine antagonist, recently
No,
launched by some
I
company?
haven't used it I still haven't used it.
And you mentioned in your talk about low dose and high dose liposuction, but your cutoff was about 5 liters. So would you take patients who are for less than 5 liters on daycare basis?
So one thing I think we should understand is these 5 liters that of fluid that has been mentioned, these are for international guidelines. So those patients are much bigger. Now, the same rule doesn't apply to all. It is going to depend upon the overall stature and build of the patient. So even for some small build, tiny patient, 3 liter maybe higher, what do you call, volume. So I think that would again go case to case, but yeah, as a rule or as a guideline recommendation, it is that less than 5 liters, we can go ahead.
Yeah, I'll put it that way, Jason. Actually, you should not be more than 10% of the body weight.
Correct.
Okay. So suppose 100 kg, I'll remove maximum 10 liters in that day, and that patient can be daycare. I've removed 24 liters, 25 liters also in patient, but then they're overnight. You have to stay overnight. You have to monitor them well for the input, output, intake, output chart, everything. But I'll put it that less than 10% of the body weight is the ideal.
Okay, sir. Jason ma'am, again, there was a case of a patient having fat embolism during liposuction, like it's there in the literature many times. So, how frequent is it, and can we do anything to prevent that? Like fat embolism and hyperkalemia. Those two things are mentioned in the literature.
Sorry, I didn't get the question. It is asking me if there is a fat embolism, how I would go about it.
Is there a way to prevent, anything that you can do before and then after, if it happens?
So for fat embolism, it's mainly if we want to prevent, what we need to do is we need to maintain adequate hydration in the patient, the pressures. And they also suggest that a cannula more than 3 millimeters, if used, a bigger one, the chances of embolism are lesser. Now, as far as fat embolism is concerned, it may still happen. And despite that, it is a clinical diagnosis on table. So in such cases, what you see neurological manifestations, hemodynamic changes, petechiae may be visible. So those are the few things that we follow, or the GERD's criteria that is there, that has major and minor criteria. So we follow that, and then it is all clinical supportive measures that we use. Hydration, inotropic support, maintaining the ventilation, oxygenation.
And hyperkalemia, anytime you have encountered, because that was one thing mentioned in that case report. The patient had hyperkalemia, pulmonary embolism, that is pulmonary fat embolism.
There are reports, this report of hyperkalemia in fat embolism, yes, I have read, because they say that the fat cells, they also have a good amount of potassium, which is released into the circulation. But I have never encountered it, but I'm presuming we do all supportive hyperkalemic measures.
One question was about not using bupivacaine and ropivacaine, but I recently had a case where they used ropivacaine for liposuction. I somehow couldn't interfere there because I wasn't the regular anesthetic. I had gone as to somebody else, to help somebody else. So is it advisable
to use ropivacaine?
It should not. Yeah.
Sorry, so I can't hear you. So I can't get you clearly.
You said
bupivacaine
shouldn't be used.
Asking about bupivacaine. Is it tumescent fluid or that's the main thing, na?
In the tumescent fluid. Yes.
See, normally, from the American Society of Plastic Surgery and Cosmetic Surgery, they don't recommend. But we in India are using in and out. I mean, it's a combination of Zylocard plus bupivacaine in the intimation fluid with epinephrine. Okay, but then the amount of bupivacaine very less bupivacaine compared to lidocaine. It's almost 1 liter of Ringalacta solution. If I'm doing only plain liposuction, then I use 2 ampoules of epinephrine, and I'm using 10 cc of Zylocard and about 5 cc of bupivacaine. That's the main thing. But there are chances of, I mean, the American Society says that no, the chances of cardiac toxicity is there. But I think low dose doesn't make difference. And second thing, when the epinephrine is used, because of vasoconstriction, less thing is absorbed. And most of the tubular fluid comes out to liposuction within half an hour. The absorption is low.
Thank you, sir. Smriti, please.
Yeah. So there was one question with respect to Dr. Aditya, so I would like to hear his expertise in this. It is unrelated to the medical side of it. It is actually with respect to these patients being healthy perfectionists. Are there any practical tips that you would like to give to us when we're talking to such patients with respect to soft skills or something that we can do to comfort the patients even further, non-medically?
Question addressed to me. See, most of the patients are high-profile patients. I mean, you consult them properly. And even when a daycare procedure, you tell them that don't worry, my hospital is open 24/7. The staff is quite competent, and give them your cell number. Share your cell number with them. It's the best thing. Okay, and tell them I'm staying here. I'll be available anytime. So then this will, I mean, the rapport is built up with them.
Thank you, sir. We could move on to our last topic for our last, the panel questions for our last topic. I would like to ask, there are reports that suggest that there is a 50-fold increase in serum prolactin due to stress under GA in IVF patients. Would it be warranted to use bromocriptine, which is a potent dopamine agonist, to suppress these transient hyperprolactinemia that is being used by the anesthesia or the surgery itself? Would that be better for the embryonic development? Dr. Rupa, are you?
I can hear you. Hello, everyone.
Yeah, thank you.
So,
Hi.
as after an ovum pickup or after any short GA or any surgical procedure, prolactin is likely to rise. But if you're not planning an embryo transfer in the same cycle, this prolactin is automatically going to settle down in the next few days. And we are going to give her a course of contraceptive pill prior to embryo transfer, which will happen 2 months later. So that the patient has 6 to 8 weeks to settle down before her embryo transfer actually happens. The only problem hyperprolactinemia causes is prevents follicular growth and prevents endometrial growth. We don't need follicular growth because we have already done an ovum pick. What we actually need is only endometrial growth, which we are going to expect after 6 weeks. So even if she's not given any medicines to take care of the hyperprolactinemia for that short duration of 2 weeks, it's not going to bother her. But if she is a patient with hyperprolactinemia, which we always test prior to starting medicines for ovulation induction, then cabergoline is what we prefer. We give it to her for a short duration of time, twice a week, for either 4 weeks or 6 weeks, to bring the prolactin levels down, so that when we start giving medicines to build the endometrial lining prior to embryo transfer, we get good response to the external estrogens.
Thank you, ma'am. Question to Alpesh, sir. Are there any differences in the anesthesia management for patients before that are coming for IVF procedures, pre-fertilization and post-fertilization?
For IVF procedure, correct?
For example, if pre-fertilization,
pre-fertilization, they generally come for either ovum pickup or some kind of, they have cervical stenosis, and for cervical dilatation, they are posted. So the choice of anesthesia will remain the same, Tiva. So you can use your routine medicines like midazolam, propofol, fentanyl, and all. Not for post fertilization, they generally come for embryo transfer. Basically, 90% of embryo transfer are done under local anesthesia only. Some of the patient might require anesthesia. So the important point is key, you should avoid ketamine in such patients. Now, ketamine being a prokinetic type of drugs, it increases the uterine peristalsis. So it may affect the embryo implantation in that. Propofol is very safe for such patients. You can give propofol and fentanyl combination and it works very well for embryo transfer patients.
So ketamine should be avoided before
After.
pre-fertilization. But in the pre-fertilization phase, you had mentioned that it does get secreted into the follicular fluid as well.
No, ketamine is not secreted in follicular fluid, but it increases the prolactin levels a lot.
Okay.
I generally keep ketamine as the last dose, and if I use ketamine, I use it in just analgesic dose, just a minor pinch of ketamine. That's it. Otherwise, propofol handles it very well.
And what would be your take on inhalational versus intravenous agents, which would be preferred? Since there have been controversies in whatever studies that I have read, in the whatever that I have read.
Tiva is the choice. Now we have got propofol is there. Initially, thiopenton was used, which the problem with thiopenton was that the recovery was very delayed. So generally, they used to opt for general anesthesia, where you give some kind of scoline or muscle relaxant, so that your total requirement of anesthesia goes down and patient recovers fast. But then general anesthesia, both nitrous oxide and halogenated agents, they hamper the IVF success rate. So now you have availability of such newer drugs, so why not go for Tiva? And the answer, if you ask me which one to use, Tiva is the answer for that.
Thank you, sir. Also, in ovarian hyperstimulation syndrome, Rupa ma'am, question directed to you. Would you prefer postponing the ovum pickup, or would you want to go ahead with the ovum pickup?
So here what we need to understand is what causes ovarian hyperstimulation. So 50% of patients who do undergo fertility treatment have PCOD. And PCOD is developing too many follicles in too soon a duration, which produces excessive estrogen that causes the hyperstimulation. In order to prevent hyperstimulation, the first step that needs to be done is we need to choose the correct trigger that is to be given prior to ovum pickup. So when decapeptyl is used as trigger instead of HCG, the chance of hyperstimulation in a PCO patient automatically drops by 70%. So if a lady is predisposed to develop OHSS, even in future cycles, despite giving her insulin sensitizers for a few months, her chances of developing OHSS is going to remain high. So we have to do her ovum pickup at some point. The way to prevent is to give her decapeptyl on the day of oocyte retrieval. After retrieving oocytes, the first thing what we do is give her antagonist. Antagonist is decapeptyl, 0.25 subcutaneously daily for 5 days. Give her cabergoline, 0.5 milligrams daily for 5 days. Start her with letrozole, 2.5 milligrams BD for 5 days. And give her a blood thinner like enoxaparin, or that's Lonopin, 40 international units daily subcutaneous for 5 days. Despite this, if she has a lot of space collection, we'd like to give her albumin on the day of ovum pickup, on the 3rd day and the 5th day. Despite this, if there is ascites or pleural effusion, we would contemplate a paracentesis on the 5th day. The best way for OHSS is to prevent OHSS by giving her the correct trigger, which is decapeptyl.
Thank you, ma'am. Tejveer sir, over to you.
Ma'am explained it so well. I mean, with all the details. That was the last question directed to her, actually. Which means if you're giving these drugs for 5 days, the patient won't be on OPD basis, I believe. If you are suspecting ovarian hyperstimulation.
So ovarian hyperstimulation will give us a clue by the 8th or 9th day. For IVF, patients start taking injections, which are gonadotropin injections from the 2nd day onwards. From the 8th or 9th day, while doing an ultrasound, if you can see free fluid, we know that this lady is at high risk for hyperstimulation. We already give her decapeptyl. Because of ascites, there is bowel wall edema, and the first symptom that she will have is nausea and vomiting. And the nausea and vomiting is so intractable that it causes intravascular dehydration, which predisposes her to DVT. So what we need to make sure is to curb intravascular dehydration. Second thing is it reduces blood flow to the kidneys and can cause tubular necrosis. So we need to maintain hydration while making sure that third space collection does not increase. So the key is IV hydration, continuously maintain urine output, and make sure you give her good antiemetics and medicines to reduce acidity so she does not lose more fluid by vomiting.
Thank you.
We keep indoor for 3 days. The OHSS is worst on the 5th and 6th day. By 3rd day, the ovaries, which are completely swollen, begin to regress slowly. So if by 3rd day she is taking orally, then we send her home on high protein diet.
Thank you very much. Finally, last question again to Alpesh. You have mentioned all the drugs and everything. I would again want a take-home message of if you are giving certain drugs, which drugs not to give for ovum pickup, because that is the commonest thing that we attend. Like you said, embryo transfer rarely requires anesthesia. So what to avoid? That I want as a take-home message for you.
Inhalational agent definitely to avoid. Otherwise, all the drugs you can use. The key is to keep the exposure duration to the minimum amount. And if you ask me specifically which drug to avoid, I will say avoid giving ketamine or keep ketamine as a last choice. This ovum pickup patient or embryo transfer patient, if you give a good dose of propofol, the pain and or if you keep a very deep anesthesia, so this pain part is covered up. So there is no role of ketamine in such. So I will say avoid inhalational agents, avoid nitrous, and avoid ketamine.
Thank you very much. Smriti,
Can I
anything
just
else?
one thing?
Yes, ma'am.
For
please.
ovum pickup, the key is that the patient has to be in extreme deep anesthesia, because our pickup needle is so close to important vascular structures which are next to the ovary, that is the great vessels of the pelvis. So the patient has to be deep, and while the patient is deep, she should not desaturate. So the key to anesthesia is to maintain that depth without having any vital compromise while inducing the patient, which I must mention, as Alpesh does really well.
Excellent.
Thank you, ma'am. Thank you.
So Alpesh has his name as ketamine on the WhatsApp, but he doesn't use ketamine.
One final question from my side of all the speakers and the panelists. What is your take on, say, central neuraxial blockage, saddle block, or spinal for daycare process? And if you are giving, what are the discharge criteria, any guidelines regarding that?
Can I answer, sir?
Yes, anybody, all of you can answer.
Yeah. Sir, I personally feel that giving regional anesthesia for daycare procedure is overkill. Just in case if you are seeing you have a case of difficult airway, like you see a very morbidly obese patient for daycare procedure. So in such cases, you can opt for central neuraxial block to avoid airway complication. Drug modification is important here. Instead of using bupivacaine or long acting, you can opt for ropivacaine. And basically, these IVF procedures usually all the procedures can be done easily under saddle anesthesia, which require very low volume of spinal anesthetic drugs. So you can give in such cases, but prefer to avoid central neuraxial anesthesia in such patients.
If the requirements so suggest that a central neuraxial block has to be given, what would be the discharge criteria according to you in such a patient in which neuraxial anesthesia has been given?
Discharge criteria remains the same of daycare procedure. Whatever discharge criteria is there for daycare procedure will remain the same. So in that, one of the point is the patient is able to void. Secondly, patient is able to ambulate independently without any support. If patient is able to do this too after having received central neuraxial anesthesia, that means the effect has already been gone. And you have a accompanying person also, and you explain them when what to look at for in cases at home also, and when to contact in case of any emergency and all. If they are willing and patient is receptive and all, definitely these are the criteria. Criteria will remain the same. Whatever the daycare discharge criteria is there, it will remain the same for neuraxial blockade also. One of the point is that you should generally prefer such cases in morning. So by evening, so you are definitely sure that the effect is been away and you can easily discharge them.
Thank you, sir.
Any more questions? No more questions in the chat box actually. So, Rao sir, with your permission, can we wind up? I would like to request Dr. Alpesh to give an introduction about Yuva Mahakon, which he is leading, now that we have the platform.
Yes, sir. Let me share my screen.
I think this will be the first time where we have been able to finish on time. All the
Today's speakers and panelists were excellent. That's why we could keep everything in time.
yeah. Rohit, you have done a good.
Is my page available visible? My screen is visible.
You could make it full screen, sir.
Yeah, I am seeing it as a full screen. Is it visible there?
Yeah.
Yes, sir. Thank you, sir.
So this time ISA Borivali in association with SAMS is organizing the fourth Yuva Mahakon 2024, which is scheduled at 2nd, 3rd, and 4th. We have planned GCC very, and we have a lot of Mahakon planned. Like we have good academic activities, especially for the post-graduation students, which include poster, paper, quiz, and they will have a lot of PGs will have a lot of you can say excitement, and they will have a fun in this. Also, we have kept separate lectures dedicated to the freelancing anesthesiologist also in our upcoming Yuva Mahakon. We have kept 4 pre-workshop on 2nd of August 2024. First one is for the airway, second is for the regional anesthesia workshop. Third one, we have kept a focus workshop this time. And fourth one is the BCLS certified course. This is an IRCF recognized course. So I would request if anyone is interested, please do join us for this Yuva Mahakon. Thank you.
Thank you so much, sir.
Rao sir, any final words before we finish today?
No, I think you have done extremely well. And Alpesh had put his backdrop as your mark on. That was a nice gesture. So I think you can say the vote of thanks and we wind up.
Yes, the most important part now, the vote of thanks. I would really like to thank all my speakers today and the panelists. They were all excellent. In fact, the number of webinars that we have done recently, today, in spite of having good attendance, there were hardly any doubts after the lecture was over in most of the cases. In fact, some of our questions that we had prepared, we couldn't ask because the speakers had already covered everything. So it was the most satisfying webinar of all today. I like to thank everyone personally, but then there's no point. All are present here. So, esteemed speakers, panelists, ISA Borivali, Office Bearer Rao sir, Larut sir, thank you all. And we'll continue to have similar webinars alternate month. And the next will be in June, we'll have a physical CME. The details will be out on the groups soon. Thank you very much for joining us. And thank you again to all the esteemed speakers. Thank you.
Thank you, sir.